Good morning, everyone. And today's first session by Professor Dr. B. Nagarajan on challenging dermatological case studies in felines. And Dr. Nagarajan needs no introduction. And anyhow, I'm telling that he is a former professor of clinical medicine, Madras Veterinary College. And then presently, he is our chief patron, Small Animal Practitioners Association of Tamil Nadu. And he is the president of Indian Association for Veterinary Dermatology, and probably every one of you know about it. And I give this stage to Dr. Nagarajan. Sir, please.
Thank you, Dr. Venkateswaran. Today we are going to see an interesting session. There is challenging cases, dermatological cases in feline practice. See, whenever you talk about feline, we have common problem in India as far as dermatological problem is concerned. We have got, first thing is parasite. Next thing is fungus. Third one is allergy. So these three things are very, very important area where we have to concentrate for our practice. So skin disease in cats mostly clue with the reaction pattern. So the reaction pattern means there are certain pattern which is very specific for cats. See, one is we have head and neck lesions. Hello? Yeah. Head and neck lesions, then self-mutilated alopecia. See, because of bite and taking away the hair, they develop alopecia. The third one is miliary dermatitis. The miliary dermatitis, you keep on licking, So they will form dirt and they will form like a millet. So that is called miliary dermatitis. Then the fourth one is eosinophilic complex. So the eosinophilic granuloma complex, that is the one which is very specific for cat than dogs. So these four reaction patterns are very common in cats. Whenever there is an allergy or whenever there is a skin issue, we can expect to have all these four reaction patterns. As I told you, the reaction patterns are head and neck lesions and self-mutilation alopecia. Third one is miliary dermatitis. Fourth one is eosinophilic granuloma complex. So these four things are reaction pattern. Unfortunately, be associated to several causes because there is no specific cause for this reaction pattern. We cannot say with this reaction pattern, this is the disease like that. Because group of disease only we can assess. And it is never pathognomonic. Say, by seeing a eosinophilic granuloma, you cannot say this is an atopy, this is a flea allergy, or anything can be there. But there will be a group of diseases which are responsible for it. Distribution is very important than the reaction. When the reaction pattern, how it is distributed, whether it is head and neck, whether it is restricted to the abdomen, whether it is in the belly area or in the extremities, that is the location of the localization of changes which is there in the body, which is very important. So the lesions, how it is distributed, that is very, very important. Difficult to diagnose because the grooming behavior of the cats. response to treatment trial may support the diagnosis. So that is the one another important clue for identifying the cause. So allergies have not been well defined in cats. See, in case of cat, it will be overlapping. So it may not be the same. So it will be mixed together. So always it will be overlapping. So it can have all together also. It can have allergy, it can have fungus, it can have parasite together in the same animal, or even it can have food allergy or environmental allergy or chemical, any allergy can be together. So it is that's why it is difficult to identify or treat a cat case. So say for example, it is not as site specific as in dog. So we can very well say lumbosacral distribution means it is a flea allergy. Like that we are telling in case of dog, whereas here it is not possible. So abdominal licking can lead to several diseases because of flea allergy, food allergy, atopic dermatitis, or even psychogenic. Most commonly we are seeing as a psychogenic factor which is playing a role for having a loss of hair in the abdomen. So like that, head and neck, the hypersensitivity disorders like food allergy, environmental allergy, flea allergy, all these things are leading to head and neck lesions. Viral dermatosis, ectoparasites, or skin tumors, anything can lead to head and neck distribution of the lesion. Likewise, face and feet. So if we are going to see the lesions at the face and feet, then we can very well suspect it could be a fungal infection, or it can be a microsporum or trichophyton or any other fungal infection. Apart from that, we have got autoimmune disease like pemphigus, lupus. All these things are possible if it is going to have a head and feet lesions. So you have to check where is the distribution. That is very important. So meet my meows. So these are all the meows what we are going to discuss today. What is going on in these three cats. One is Kituni, another one is Mitty, and another one is Kalu. So first one is Kituni. It's a cat, 3 years old, non-descriptive, male cat, 6.5 kg. So it is having a history of non-stop scratching. Treated locally for more than 9 months. No improvement noticed. So this no improvement noticed showed little response when stopped fish in the diet. Because as you know very well, for cat, dietary allergens are very important. Allergens are 3. One is fish, another one is dairy, another one is beef. All the 3 are very, very important allergens in case of cat, whereas in case of dog it is not like that. Chicken, beef, all those things. So where in case of dog we will be taking fish as a hypoallergenic, whereas here it is not hypoallergenic. That is very important. So here when we examined, it was having head erosions. You can see the erosion at the nose. You can see at the ear. See, apart from that, it was having a lesion at the lips. See, symmetrical lesion at the lip, both sides. And erosion at the chin. See here. It has got the lesion here. So all these areas, it has got the erosions. And nodules and erosions at the ear pinna. You can see the nodules. See, the nodular dermatitis is so commonly seen in case of cat for many diseases. So nodules and erosions at ear pinna. And self-mutilation of the foot, erythema of the axillary area, it has got erythema. Then erosions at the tail and foot, miliary dermatitis. You can see the miliary dermatitis. And it has got the red erythematous patches in the ventral abdomen and also in the tail self-mutilation. So like this. So it can be a plaque or it can be a erythematic patches. So what is the differential diagnosis in this? See, for ear nodule, we have got very important differential diagnosis or tumors. Apart from tumors, we have got leishmania. So in the leishmania, we have got the nodules will be located like marginally. See, the margin of the ears, you will be seeing the nodules. So if in that, if you are going to take a impression smear and stain it, you can very well locate the leishmania in the slide. So the easy to find out. Likewise, we have got other squamous cell carcinoma, mast cell tumor, cutaneous lymphoma. See, we have got lymphoma. In that also nodules and erythematous plaques are common. So it has to be differentiated with these three tumors. That is very, very important. Squamous cell carcinoma, this is a mast cell tumor. It can be benign or malignant. Most of the time it is benign. More than 80% of the cases are benign mast cell. So if it is going to become malignant or multiple sites, it will become poor prognosis. Whereas this one, squamous cell carcinoma, if it is going to be in the dermis or epidermis area alone, it will be easily treatable. So the time of presentation and duration of treatment, when you are going to start the treatment, that is very important. So if it is early, you can have a very early cure. So here, the squamous cell carcinoma will be having nose and ear tips will be affected, and most commonly it is due to the ultraviolet rays. So ultraviolet rays, when the cat is going to get exposed to the sunlight, which is going to have less pigment in the body, they will get exposed to the thing. The squamous cell got irritated and they will get mutated with they will get stimulated and they form more cells, mitotic cells, so leading to squamous cell carcinoma. So that they can also go for a systemic involvement. So before that, if you are going to identify, that is very easy to cure it. So we have got large number of treatment for it. So both squamous cell and mast cell tumors, nowadays we have got, recently they have got Palladia, that is the tablet by Zoetis. They have brought it, and it is easy to administer orally, weekly, twice. It can have cure within 5 weeks. So like that, we are having a lot of latest invention in our profession. So in this case, we have taken ear swab, it is negative, there was no parasite in it. And skin scraping, it was also negative. And wood slamp, we have taken the wood slamp, it is also negative. And cytology, we have seen a lot of eosinophils in it. So it is more of what? If it is eosinophilic, means more of allergy. So allergy may be the reason, or even parasite may be the reason. So these two are very important. So culture, there was no growth in the culture. So when we have taken biopsy, because we have to rule out the tumors, so we have taken the biopsy. In that biopsy, it was showing granulomatous inflammation, that is epidermis, irregular acanthosis, and infiltration of the histiocytes, neutrophils, lymphocytes, and plasma cells were seen in this histopathology. So it is confirmed as a granulomatous inflammation. It is not, the nodule is not because of any fungus, or it is not because of tumor. So clinically, we have identified what are all the things we can see. We have got a Favorite et al. Criteria to identify whether it is atopy, feline atopy or not. Feline atopic skin syndrome, it is called. So to identify that, the presence of at least 2 body sites affected, that is very important. So yes, we have got very many sites being affected, and it was having miliary dermatitis, and it was having eosinophilic dermatitis, and head erosions were there, and presence of any lesions at the lip, definitely it is there. Presence of erosions or ulcerations on the chin or neck, yes, it is in the chin. Absence of lesions on the rump. So all these things are more than fulfillment of 5 or 8 criteria. 5 of the 8 criteria will give 75% assumption towards allergic dermatitis in cat. So here we can very well consider this as a feline allergic dermatitis, but is feline atopic skin syndrome, that is called, recently they have coined as feline atopic skin syndrome. So it is an inflammatory and pruritic skin syndrome in cats, and it is manifested by spectrum of reaction patterns. It can be with any pattern what we have discussed, none of which are specific for the syndrome, and that they may be associated with the IgE antibodies to the environmental allergens. So the food allergy and flea allergy can be both either mimic or contribute to this syndrome. So it can be coincided with that, or it may be overlapping each other. So it is very important to rule out all those diseases while treating the case. So that is very, very mandatory. So whenever you are suspecting any allergy, you have to treat for flea, you have to go for dietary trial. Then only you have to rule out. It is by exclusion. The diagnosis is by exclusion. So here the potential role must be assessed before deciding the therapeutic approach. So how I treated this case? So I have given dietary trial. There is having a partial response. Dietary trial has to be done with the analergenic diet. See, the analergenic diet for cat is available with the Royal Canin. You can use that. That is a very appropriate way to go for going for a dietary trial in food allergy, either dog or cat. We have to go for an analergenic diet. Then parasite prevention trial, that was done with the broadline. And antibiotic, I have given convenia, that is cefavaxine 8 mg per kg, once I have given. Then methyl prednisolone acetate 5 mg per kg, I have given subcutaneously every 2 weeks for 2 weeks. Then cyclosporin 7 mg per kg, I have used Ichmune C syrup for this 7 mg per kg per day. And I have given Alladam spot on. It was showing a very great response for this. So it was having a less, see the lesions are improving and the nodules are not there. It was showing a very great improvement. But when they stopped the cyclosporin, the lesions at the nasal area, that is nasal bridge, has reoccurred. So it is very, very, even the foot lesions have gone. See, even the axillary lesions or abdominal lesions are gone. See the response in the tail. So it was having a very bad self-mutilation. Then it was having a hair growth while applying the Alladam and other thing. So it was showing a very good improvement with the treatment. So what is the etiological therapy? We have to go for allergen avoidance. Fleas and food, easy to avoid. House dust mite, pollen and molds are not easy to avoid. So limiting the cat's access to bedrooms, it is very important to go for spraying the benzyl benzoate. You can use that so that it won't have any house dust mite in the area. Then immunotherapy, we are not following that in India even for dogs. So it will take long time to go for it. And there are certain other treatment types we have, like cyclosporin, corticosteroids, methyl prednisolone, aclocitinib. There is Apoquil. We can very well go for it, 1 mg per kg body weight. And maropitant, that is Serenia. That is also not available in India by Zoetis. Very soon we will be getting it. So that is easily we can use for treating the case, 2 mg per kg body weight. And we can very well go for hydrocortisone aceponate, Cartovan spray. That also can be used for treating the cases. So there are literatures stating that Apoquil, that is aclocitinib, is going to work very well for the this type of feline atopy at the rate of 1 mg per kg body weight. And we have got increased expression of cannabinoid receptors in cat. We have got a very good response with the cannabinoid receptors by using this palmitoyl ethanol amide. There is nothing but a hemp CPD oil. So at the dose rate of 10 mg per kg body weight, every 24 hours for 30 days if you give it, so very good improvement. So you have to remember, by seeing this case, what we are remembering, we have a feline atopic skin syndrome with a 72% of the cat with a less than 3 years of age, and 12% maybe more than 6 years in case of cat, unlike dog. Whereas in Persians it is so common, that is what we are seeing in our area. Then there is chance to have the GI signs, and mostly 9% of the cases will be having GI signs. Respiratory signs also there, 6 to 7%, which is very commonly seen in cat than the dog. Respiratory signs with the atopic dermatitis is so commonly seen in cat. And otitis, both in dog and cat, we have got otitis 16 to 20%. So here, concomitant, we can have food allergy, 13% of the cases. So seasonal signs, 12 to 18% of the cases. So we have to remember that immunotherapy is the best solution, but we don't have the allergen panel here. We have not done work on it. We have to be seriously doing it. In future, we may be having it. And corticosteroids and cyclosporins, apoquel, like oclosutinib, antibiotics, ichimune, all these things will help a lot to improve the condition. So in nutshell, we have to remember that age commonly less than 3 years of age, and we have to expect the clinical syndrome with the different patterns, reaction patterns, and we have to check with the head, mouth, neck, and abdomen and trunk, and exclusion diagnosis has to be taken care, and therapy, what we have discussed, we have to follow. That is a very important thing, because it is difficult disease for animals as well as for the owners. So we have got a very good response with the treatment, but that has to be continued continuously, then only it will be maintaining. If you go for immunotherapy, it will be, we can stop everything slowly. Next case is Mitty. The Mitty is a Persian female, 4.5 years old. It was having a history of vomiting, licking at the back for a few days. Keep on licking at the back. That was the history he was given. And the vomiting was with full of hair. So it was licking and throwing hair in it. So that was the history. And while examining, it was having a black dot, dirt-like thing sticking on this ridge of the nose up to the inner canthus of the eyes, and also the nasal bridge. We can very well see that. And when examining the ear, it was not having any discharge, black discharge or anything. But owner wiped out the dirt the externally when he just before coming to the clinic. That's why he was telling, when I asked, there was no discharge, he was telling this. So we have done face and tail excoriation, we have seen in this case, and hair loss around the lip. See, the tail was having excoriation, face also having excoriation. So here, hair loss and excoriation is so common, and hair loss, excoriation you can see at the ear tip, the pinna of the ear and tail area, and in the head area you can see this. So by seeing this, what we can suspect? If it is going to be a parasite, what you will suspect? Ear mite. So here, when we examine in the ventral abdomen, it was not having anything by naked eye. When you go closer, if you have a wood lamp, you can focus it with a lens, or if you have nothing, you can go for using your phone, and you can go for seeing with the camera and enlarging it. You can see like this. I have done with my iPhone. It was showing a pepper sprinkled appearance. See, the pepper sprinkled appearance, say when you magnify it, you can very well see in this area, lumbosacral area, posterior half, and also the hind legs, and also the ventral abdomen. These places you can see the fur mite. That is the thing, what we have seen. The ear swab. What we have seen in the ear swab was autodactic cyanotis. And it can be a male or female, we can find out by seeing the organs. See that we can very well appreciate by seeing the pattern we can see. And also we can go for diagnosis with the otoscope, but we have not done that. And Lynxocara, that is the firmite. That firmite, it is having a cylindrical body. You can have a head plate and propodosomal plate and also the opisotomal plate. So in here, in this area, if it is female, it is not present. This particular plate is not present in female. That is opistostomal plate. So that will be looking like a fingerprint. So you can see the striations there. So that is the thing. If it is going to be a male. So here we have taken a tape impression in that area where it has got the sprinkling of the pepper-like appearance. Sorry. It was showing the parasite, Lynxocara. If it is with the tape, when we go for a coat brushing, we have more number. This is with the ear mite. When we go deep and take out with the ear bud, we have seen large number of ear mites in this case. And also we have seen the fur mite, which was very clear while having a coat brushing at the back and also on the ventral abdomen and the other area, that is the legs. Particularly around the tail, if you are going to take, in our study we have identified the more commonly you can see in the perianal area and tail area. That is in the around the tail area. If you are going to brush it, we can get more number of parasites like this. So I have treated this case with the Celafort, that is selamectin. It was having a wonderful effect and it was showing a very good response. But we do have a lot of options for it. Initially we were treating with the ivermectin. So the ivermectin is not safe in case of cat because there is chance for getting toxicity, say particularly in the Persian and all, and if it is going to be very low in weight, you will be having a lot of issue. So we have got various number of drugs for treating this condition like melbimycin, imidacloprid, spot-on, amoxicillin, and selamectin, moxidectin fluoroner, that is a Bravecto, and also the selamectin sarolaner. So these drugs are also very much useful, fluoroner, all these things are also very much useful. Apart from that, recently they have identified this afaxaloner, that is afaxaloner is the one which is the latest drug which is by NextGuard combo. That is also going to take care of other parasites like, because it is having a praziquantel, the tapeworms also will cover. And another thing by felpriva, that is one another thing, digolaner. These are all the things in the pipeline that by etoquinol. This one, pispirozole, it is a group of pispirozole which is having an equivalent effect. See, all the isoxazole groups are having more than 95% effect. So this also they have identified, it has got a very good effect and comparable to the isoxazole group. And we have done a study in that ivermectin also worked out very well, but because of the toxicity, we are not recommending to go for ivermectin. So in the lot of studies has been done, they have given sarolaner was more than 95% effective, and fluorolaner, and 2 applications of moxidectin imidacloprid on the body, weekly intervals. You can have, that is 2 weeks interval, you can have a very good improvement. So what we learn from this take home is thorough physical examination, coat brushing, tape impression, ear swab are very much useful in the diagnosis, and isoxazole, salamactin are very effective for skin parasites in cat. Our third case is Kalu. The Kalu is a cat which is a Persian, 1 year, 2 months, female cat which is having 2.1 kg, which is having outdoor access all the time, condition for 1 year. Animal was having a problem for 1 year and slowly progressing. That was the history, and treated by different vets locally with selamectin, broadline, canworm, grisofulvin, demosquenil, Clobust cream, that is a steroid cream for more than 9 months. So ketochlor shampoo was used. Actually for cat it is better to avoid ketochlor shampoo because ketoconazole is highly toxic in cat. So you have to go for meconazole. So the steroid shampoo tablets or cream also you should not go for continuously because they develop a lot of side effects even in cats like dog. The physical and dermatological examination what we have done in this case was showing weakness, dullness, weight loss and poor body condition score. That was very much obvious by seeing the case. So alopecia, hyperpigmentation, dorsal body, you can very well appreciate this alopecia and hyperpigmentation. And also in the tail was having full of alopecia and it was having a dry coat, it was having a very bad smell from the body, and paronychia, that is inflammation of the foot or nails, inflammation of the front and back nails was there, and onchomediosis, that is having severe loss of nail in the front. So in the some of the nails have been lost, that is onchomediosis, and also onchorexis, that is the crackling of the nails, thinning and crackling and having a thickening. All those things are seen in this cat. See, you can see the oozing ulcers, all the legs, crust, scales all over the body. And there are multiple lesions. You can see in this case, there are multiple lesions. You can see in the foot, you can see in the tail, you can see in the ventral abdomen with ulcers, and you can see in the paws, all the inner thigh, everywhere you can see the lesions. So ulcers seen at the ventral trunk, alopecia, hyperpigment, dorsally, hyperpigmentation. So the granulomatous nodules, left thigh, you can see this granulomatous nodules, crusty nose was very crusty, and purulent discharge, both from the eyes and nose. So it was so horrible to see the cat, and it was having a full of smell. So we have done the diagnostic work. So we have taken the skin scraping, negative for parasites, cytology, impression smear, pyogranuloma with the fungal hyphae was identified, and fungal culture, hylohypomycosis, that is the finding. We have done the wood slab. What you are seeing here is apple green fluorescence, isn't it? See, what you are seeing here is apple green fluorescence, but we have to check with a caution. False positive results in the wood lamp examination is always possible, as in this case. So in this case, what we have seen is all with the crusty area. It is not with the hair. See, the hairy area are not fluorescent. It has got only in the crusty area or in the place where they have applied the medication is having the issue. So the topical medications, that is false positive, they can create false positive. And the detergents, fibers, and certain bacteria like Pseudomonas and lice, live nits, they can also create false positive. Scales, crust, dead skin cells, the hair should be glowing, not on the skin. So we will be seeing in the skin glowing, but it is not the case. We have to take the hair and see under UV rays, there is wood lamp, it should glow. Then only we can say it is a microsporum positive. So only actively infected growing hairs fluoresce, up to 80% of microsporum canis cases. So the core diagnostic test in cats, this is considered as a core diagnostic test, only suggest, not rule out. Fungal culture is always recommended to confirm the infection. Negative wound wood lamp examination does not rule out microsporum canis infection. So you can see different colors, not if it is not going to have an apple green fluorescence, instead if it is going to show blue color, that means it is a normal skin. If it is going to show white color, that means a thickened skin. If it is going to show yellow color, that means it is an oily skin. If it is going to be a purple in color, that means it is a dehydrated skin. So like that, we have to understand the how it is working, then only have to interpret. Otherwise, you will go wrong in it. And also there is possibility to have a false thing. Animal may not have it, but it can pick up the infection from the neighborhood or any other animal, or it can get contaminated from the nearby environment. So that is also possible to have it. So here we wanted to have, after seeing the wood lamp negative, we had to go for a punch biopsy to rule out what it is. So we have taken these sites for taking a punch biopsy. So 4 to 6 mm punch, skin punch is very much available. You can very well use that, go for punch biopsy. In this case, it was confirmed as a fungal granuloma. So in addition to histopathology, fungal culture, molecular fungal identification should be carried out for identifying the exact fungal antifungal agent. Because we have got various antifungal agents, it is very important to recognize what type of fungus it is, so that we can opt certain drugs for which is more suitable for that particular condition. So we have got opportunistic fungus, that is also very commonly seen nowadays, even though it is rare. Definitely it is rare, but we are also having this. That is what we are trying to say here. We have got hypomycosis and hylohypomycosis and eumycotic mycetoma. All the 3 different type of fungus we are having as an opportunistic fungus. They have got lot of genera in it. The hypomycosis is having various things. They will develop hyperpigmentation, that is more of melanin pigments they will produce. And if you are going to see under a microscope, the hyphae will be having a black colored appearance. Even if you are going to see in the growth of the fungus in the culture, you will be seeing full of black colonies. Whereas here in the hypomycosis, this is also a group of fungus which are having as an opportunistic fungi. We can very well have as a single or multiple. So in that, you will be having hyaline as a deposit. There is a transparent hyphae you can see. So that is what you are seeing. And in case of mycetoma, you will be having a black and white grains like appearance you will be seeing in the growth of the area. That is eumycotic mycetomes. So here we have got 3 different things. Hylohypomycosis, which is more suitable for our finding. See the nose and bridge of the nose and nose, rest of the face and head, and all the limbs are being affected, and trunk area and the tail area, all these things are being affected with this case. So that is what they have seen. Nodular granulomatous fungal disease of cats in United Kingdom. They have done a retrospective study and they have given a review. So in this, they have given a report which was so correlating with our findings. And here also we have got outdoor access, greatest abundance in the late summer and autumn, and facial area and extremities in cats 16%, paws 6%, and cats may have nodules in this saprophytic fungus infection. Opportunistic fungal infection considered in the differential diagnosis with the non-healing and slowly progressive lesions. I have told you for more than a year the condition is there and it is slowly progressing. So there are reports stating that hypohypomycosis is most predominant than the other fungal infection. So we have done this study. We have done systematically, that is this nodular lesions has been because they have been using steroid for a longer time, it was having a immunosuppressants exposure. So it has been done with the whether it has got a systemically ill with any viral disease of fungus like feline viral leukemia virus. Those things will, if it is going to be there, they develop immunity, low immunity, and because of that fungal will develop. But here it is not so, because it is not having any systemic involvement at the initial stage of presentation of the case. So we have done this, and we have seen this pyogranulomatous inflammation by doing the cytology and cytological evaluation of the fungal organism we have done, and we have seen that hypomycosis as the diagnosis. So post-treatment, so we have done the treatment with initially with the convenia because it was having other neutrophils and other infections in the nails and other area. So we are given conveniently, because it will take care for 14 days. Without any oral treatment we can go, particularly the antibiotics. So we have given itraconazole as a treatment, 10 mg per kg for 6 weeks, and terbinafine cream, and also hepapite syrup to improve the liver strengthening. Irish amaze, there is the meconazole shampoo has been used. Meconazole and chlorhexidine combination, we have used that shampoo. Ask them to bath for 4 days, then weekly twice. And this was the result. It was showing a very great improvement with the treatment. But the itraconazole is successful in treating onychomycosis and cutaneous and subcutaneous fungal infection. So this is the surgical excision, or itraconazole is the very important drug of choice for treating any saprophytic fungus. And if it is not going to work out, then we can go for posaconazole, amphotericin B. Those things will have a very bad side effects. So along with the prescribed medicine, Aladam Spartan also advised 2 months. The case was followed over phone. Owner informed steady improvement. In spite of skin and coat shows very good improvement. The weakness and systemic illness was observed on the clinical examination and the investigations in the next visit. So it was very weak, even though cutaneously it was showing a very good improvement. Animal was not showing very activeness. It was having a very apathic situation, and it was very dull. You can see the face, how it is very bad and systemically involved. And considering the multiple lesions, see there are some multiple lesions means it is a poor prognosis. Multiple lesions and systemic illness, prognosis is informed to the owner as Goddard. Owner didn't turn up for review due to distance, and after 4 months when contacted over phone, he informed that animal collapsed, cat collapsed after a few days of inanition, in spite of treatment with the local vet. So it is very, very important to understand the rare opportunistic mycosis in cat also prevalence in our area, and we have got nodular presentation, which is very, very commonly seen in this particular opportunistic fungus cases. So whenever you have a multiple lesions, you have to tell to the owner it is very Goddard. The prognosis is Goddard. You should not simply say once by seeing the cutaneous improvement, immediately you should not jump into a conclusion and say animal will be all right to go like that. You should not say that. So it is very, very important to say that Goddard prognosis because it is showing multiple lesion, or if it is going to have a systemic illness, you have to tell that. So what we learn All the required diagnostics should be carried out on the first visit itself. That is very, very important. Then rare opportunistic mycosis in cat also prevailing in our area. Identify or avoid immunosuppression. You should not allow to keep on applying the steroids. And itraconazole 10 mg per kg body weight for 8 weeks will give a clinical improvement. Disseminated illness should be informed, guarded or poor prognosis to the owner. That is what we have seen as a 3 different cases. Thank you. And also I am here to inform you that we have an association called Indian Association for Veterinary Dermatology. In that we are going to have a congress. Every year we are conducting congress. This time we are going to have it in Goa. So 7th to 9th June 2024 we are going to have it. You can reserve your date and register. And also we have our World Congress in July. Anyone interested, you can very well come and you are most welcome. Thank you.
Thank you, Professor Nagarajan. Any doubts?
Cyclosporin, you had to give, initially you had to go for 60 days continuously. Then we had to go for alternate days, 60 days continuously. Then we had to go for weekly thrice. So if you are going to have improvement with the weekly thrice, you can very well continue that. And if it is not going to work out, you have to go for alternate days again. And still you have improvement, you have to go for same way, then go for weekly twice or thrice. Then it will improve in its condition. Thank you.
Thank you, Professor Nagarajan. And next, we have a sponsor session. I request Drools to come to the stage.
Thank you. Bhagati Bhutana. Sorry.
Sir, yes, 20 minutes max. So, good morning everyone. So, I'll introduce myself first. I'm Dr. Puneet and I'm working as Product and Techno-Commercial Manager in Drools. From past 2 years I've been working. And today I'm here to present about some of the products which we have and a lot about pet nutrition. So, what we are doing and what are all the channel engagement activities that we are doing and what is Vet Thrive. So, Vet Thrive is a special program which we have launched. So I'll not going to take much of the time. So I'll wrap up. I know the importance of this program. So it's been a wonderful program in Ooty, and I'll be like thankful for the SAPAC, entire team of SAPAC, for giving me this opportunity to present in front of the veterinarians. So I'll not delay. So I'll go on to we'll move on to the presentation. So about us. So before starting anything, so I'll speak about Drools, a few things about Drools. So we started in 2010. So as per as our formulations are considered, so the formulas we will get from US. So from US, qualified veterinarians and scientists, we will get the formulations, and entire manufacturing process and ingredient procurement will happen in India. So we have our production unit in Chhattisgarh, which is in India, and ours is the only pet food company which is actually having proper manufacturing setup in India, and we are supplying from Chhattisgarh, and we are supplying all over India. Apart from that, so if you see like market share, so we have garnered around 43% of market share over a period of last 13 years, I can say. So moving forward, this is our general picturization of our factories to just show you people. So global presence, so any country after local business, we have to move around. So our global presence is pretty good from past 2 years, and we have been supplying to almost 24 different countries. So from like 13 years, so we have done this. So and we do a lot of channel engagement activities. So as far as vet channel is considered, so we do a lot of CVE, so continuous veterinary education program. And also we do a college engagement activities, which is called as macroscope. So where we will bring speakers from respective fields, and we will set up a program where veterinary students will hear from the speaker about the different avenues, so which are available after completing their degree, because a lot of people after their UG, so they will not have a proper idea where to get in and what will be the avenues which they have. So to clear it, so we do this program which is called as macroscope, and people from different entities, like someone from the pet practice, someone from the army background, someone who is working in extensively in pharma, and someone from pet nutrition. So this we are doing, so which will help veterinary students to pick up their better revenue according to their wishes. So these are some of the awards which we have got over a period of last 13 years. And I'll not delay, so we'll go to the product range. So like any other market, so we do have different products, something like premium quality market products, and regular range of products, and economy range of products. So vets can identify the customers based on their need, and they can suggest the nutritional solution. So this is our one of the flagship product, which is
the sound ceases, no sound. Then this is the pressure button, you push it slowly. Please.
a lot of real chicken.
I will ask her to adjust.
A lot of the grains which are human grade. So this is one of the flagship product. So this is called as daily nutrition. So this is also available for starter, and also
The sound ceases, no sound. Then this is the pressure button, you push it slowly. Please.
very good for first aid.
I will ask her to adjust.
Trust my coaches for my exercise and nutritional needs.
This also comes with
Puppies
lot
and
of
dogs
moisture,
can
so we
trust
can rehydrate
Rules
the pet animals
Focus.
as well
This is
during
because
the summer.
Rules Focus is a specialized dry
So
food
we do have
that has
care and
all
treats,
the good
so
stuff.
which is actually a
Real
niche
chicken,
market,
whole
if I
rice
can
and
say,
oats,
but
vitamin C
care
and
and
E,
treats can
minerals,
play a major
probiotics.
role to,
What
train
it
the
doesn't
animals
have
to
is
make them
wheat,
swallow the
corn,
tablet,
soya,
and
fillers, or
also,
any artificial colors
maybe
and flavors
to
that
do
add
something
The
unhealthy
sound ceases, no sound. Then this is the pressure button, you push it.
So whatever the technical thing says, scientifically, we should not exceed 10% of the total diet. So your care and treat should be, so it should be around 10% of the total diet. So a lot of pet parents may misguide and overfeed it, so which ultimately leads to the obesity. So that should not happen. So we do have premium range of product, which comes with single grain formula, and also we have zero grain formula as well. So single grain formula, only rice will be there, and apart from that, so real chicken, which is human grade real chicken we say, so that will be there, and few of the antioxidants.
The sound ceases, no sound. Then this is the pressure button, you push it slowly. Please.
So this is also available for different categories of the pet population. So lastly, this is what actually we have to present in front of the veterinarians. This is prescription diets. So a lot of people know that prescription diets, what role they are playing, so in supporting the treatment perspective. So why actually this therapeutic diets are needed? So a lot of the time, so we do give antibiotics for the if they have any bacterial infection, and analgesics when the animal is in pain. But what about the secondary complications? So usually animals will face a lot of secondary complications. For example, if you take renal issues, animals will suffer from hyperphosphatemia and low vitamin D synthesis. And this phosphorus can be provided, and vitamin D can be provided in the diet itself. So that can correct the entire secondary complications. And also skin and coat issues, they need a lot of fatty acids, so to rejuvenate the skin, so that will be there. And apart from that, in obesity, you guys need to provide a diet which is having a lot of fibers where the energy will be less. So calorie less, and also the fiber rich diet we have to support them. So these kind of scenarios, the vets have to switch into the diets which will usually help in treating the particular condition. So we have a few of the diets. I'll just walk through the which are all the diets we have for the veterinarians in terms of prescription treatment. So we have Vet Pro, so Vet Pro is completely the prescription range. So to provide entire range of products, we do have starter, puppy, and adult. And in kitten, we have kitten and adult. And apart from that, we have 7 prescription diets, where 6 will be for dogs and 1 will be for cat. And we are coming up with more of cat products in the future days. So first one is obesity. So obesity, as you all know, so a lot of veterinarians consider this as a disease. So where the lifespan of the animal by 2 years, as the research says. So obesity, you need to provide a diet where, as I told earlier, so fiber will be rich and calorie will be less. So our diet, specifically obesity, so has helped a lot of veterinarians. In less than 45 days, the animals have shown a result of losing 3 to 4 kg body weight in total. So a lot of pet parents, what they do feed a lot of table scrapings and a lot of treats, so which will ultimately result in obesity. As far as the research says, in India, almost we have 38 to 42% of the animals which are obese. So that's why obesity play a major role. So we do have so lysine in the diet, and choline and carnitine, which helps in fat mobilization, and high fiber and low calories, and yucca extract will be there to reduce the stool, to manage the stool odor. So this is about obesity. And skin and coat. So skin and coat, as you all know, so one of the majorly seen cases in veterinary practices. And skin and case, like it is hard to, since I have also practiced it in my early career, I know it is hard to convince the customers to have a longer process of treatment when solving the skin and coat issues. So skin and coat, so it's a diet from us, so where, so nutritionally,
Watching your little pups grow into big boys is a bittersweet journey. They need love, attention, and focus at all stages. And while they change and evolve, their food needs to evolve too. The Drool's Focus range is built exactly for this reason, to give them the best of everything at all ages. For little pups, it's more meat and less grain starter formula. For growing pups, there's a corn and wheat-free formula with real chicken in crunchy kibble. And for our adult dogs, it is a specialized dry food packed with real chicken, vitamins, long grain, rice, oats, and probiotics. Rules: feed real, feed clean.
Lot of dogs have allergy towards.
Sometimes your fully grown dog might insist on sitting on your lap like he's still a little puppy. But he can't be fed what he used to as a pup. Your dog's food needs to evolve as they evolve. And we have just the right food for every stage of their growth. The Drool's Focus range has a more meat and less grain starter formula for weaning pups during the period of 3 weeks to 3 months. A corn and wheat-free formula with real chicken and crunchy kibble for the growing puppies. And specialized dry food packed with real chicken, vitamins, long grain rice, oats, and probiotics for our adult dogs. But basically our overgrown puppies. Drool's. Feed real, feed clean.
So that will be there. So this is about.
You know, guys, everyone thinks I love myself the most in the world. And you know that's slightly true. But seriously, I love my dogs Fudge and Astro way more. Which is why I give them nothing but the best. And that's why I only feed them yummy Drools. Did you know Drools contains 100% real chicken liver and eggs with zero byproducts or fillers. And it's packed with all the nutrition my dogs need every single day. Wait, there's more. I did my full homework on Drools, let's see. Drools improves the dog's digestion, immunity and coat. It's great for stronger teeth and bones. It's got kibbles to prevent tartar. There's a vegetarian version and a special recipe for puppies. And, oh, that's it. Yay! Drool's Daily Nutrition. Feed real, feed clean.
Majorly appreciating appropriate level of protein and energy levels, and also phosphorus and sodium. So majorly they should be controlled. So this phosphorus and sodium will play a major role in complete reabsorption process. So we have provided a proper amount of that, and which can help in extending the lifespan of the animal, so in the entire course of renal diseases. So that I can say. So this is renal, and we do have mobility for joint issues. So when the animal gets old, the cartilage in the joints, as you all know, so to support that cartilage, we have a diet which is very rich in glucosamine and chondroitin basically. So this is available to solve mobility issues. So this is for joint health support. So any animals which are like getting pretty old, so they will suffer from getting up, very difficult to get up and also get down the stairs, and also they are lethargic. So for those cases, you can use mobility. So this is about mobility. And we do have gastrointestinal diet. So as a few of the things like researchers says that our gut microbiota, what we have is a second brain. So it is important to maintain the gut biota. So the microbiome, whatever we say. So to keep up the health of the entire microbiome, so we have a diet. So you can use it in recurring vomissions and recurring loose motions. So you can use along with the therapeutic support, whatever you are giving. So you can use this diet. This is gastrointestinal. And lastly, one of the diet which is specifically meant for felines, so which are very common cases, FLUTD, feline lower urinary tract diseases. For that, we have this diet. So this diet basically works for any kind of stone formation. So we can use it. So as you see symptoms, so where a cat goes and urinates outside the litter box, or cries a lot when passing the urine, for those cases, so we can easily use this diet. And we have got a pretty much good results in both in as my friends are practitioners, so we have got a good results. And so the results what we have got, they are using this diet for at least 40-45 days. They are finding it in solving the stone formations whichever happen in urinary tract infection. So this is one of the diet which we have in cat segment. So this is urinary tract infection. And so entire product range, if you see, we do have starter puppy and adult, and also kitten and adult in cat segment. Okay, so we do have supplements, so which is absolute supplements. So for calcium and vitamin, skin and coat, mobility, and also immunity and digestion. So these are the some of the supplements. And the point which should be noted is, here is, these are semi-moist kibbles, so which can be easily fed to animals, so without any forcible thing which we do usually when feeding the tablet. So that will not be there. These are chewable kibbles which can be which are eatable, so they can easily consume this. So the process of giving the supplements will be very easy with this absolute supplement range. So this is about absolute supplement range. And finally we are here, so I want to tell about the new program which we are running, so in this 2023, so that is Vet Thrive. So it is basically a clinic enhancement program, so where win-to-win situation for both drools and for the veterinarians. So few of the veterinarians who have got, so we have supplied some of the equipments to one of the clinic called as Pet Planet, so which is in Hyderabad, and also we supplied Healthy Pass Clinic in Pune. So we have got a good response from them. So about Vet Thrive, what it is, so we will see. So first, veterinarians who are actually practicing and who want to upgrade their clinic, so they can basically connect with our ASMs. So if they are unable to connect, we have given a link. So we have given a link and QR code. You can scan it and you can connect. So then brief verification will be done with the documents whichever you are providing. So then after that, information gathering, so we do. And finally, vendor, you guys can select the suitable vendor which you are knowing. So and entire installation and the guidance whichever it is required for the installation will be provided from our end. So number of equipment, so these are the few equipments which I have put to show you. So a lot of people have got gaseous anesthesia as well. so in their clinic, which usually helps them to better diagnose the disease and also upgrade their clinic in clinical practices. So this is about few of the equipments which we are providing, and we have provided almost more than 50 veterinarians with equipments through this vet drive program. And lastly, in the last slide, I have given the vendor support, so you guys can take a clip of this and you can contact us. So any doubts regarding this, you can visit our stalls. We do have stalls here only. One is Vet Pro stall, we do have Signature stall, and we are coming up with Pharma as well. So in future days, in another 2 months, we are coming up with Pharma as well. So we do need your support, and please visit our stalls for any clarification if you need. So thank you one and all for the opportunity you have provided. Thank you. Thank you, sir. Yes.
Thank you, Druls, for your overwhelming support. And we also will support you and expect your support also for the continuous one. And now, the next session, again with Professor Dr. Nagarajan on adverse food reactions in canines.
Hello, can you hear me? Yeah. So now we are going to discuss about the food allergy where vet miss. So many times, even though we have been giving repeated lectures in food allergy, still there is some doubt or some hesitance in identifying the problem in the practice. That's why when JP was asking about this, to repeat this, because a lot of vets still not in a position to understand properly, or they are missing the cases. So you please give this topic as a lecture in your session, like that he was requesting. So we are again, we will start with this. What is cutaneous adverse food reaction, otherwise called food allergy, where we miss. That is the thing we are going to discuss. First and foremost thing is we have to see what is cutaneous food reaction. See, adverse food reaction recognized as a non-seasonal pruritic skin disease in dogs with or without skin lesion. This is a very important thing. You have to remember each and every word properly. See, it is a non-seasonal. Non-seasonal means it can occur in certain diseases occurs seasonal. Certain diseases occurs as a non-seasonal. See, even in a child, even it may be a winter, it may be a summer, anytime it can happen. See, for example, in case of atopy, what is happening? It is having both seasonal and non-seasonal. See, whenever there is a flowering season, it will get flared up. The symptoms will be very much aggravated in the animal's body. That is the seasonal. Or even the flea allergy, you will be having certain seasons. quantity is important, type is so important, the source of the wheat, where from it is coming, that is also very important. So these things we have to remember. Confusing clinical presentation. So meet my patients, Tiger, Caesar, Sarkozy and Jackie. So the Tiger, Labrador, 2-year-old male, shaking the head frequently, recurrent ear problem, pruritus, treated with antibiotics, aortic preparations, respond temporarily, not responding to steroid treatment, which responded initially for week. After that, even if you are going to give steroid, it is not improving. That is the complaint. Presently, no ear preparations for 20 days. Clinical signs, when we examined, it was showing pruritus, otitis externa, erythema, and more secretions. So when we clean the ear, it was showing more secretions. So what are all the differential diagnoses when you are going to have any otitis externa? So parasites, first you have to remember. So the otoductic scabies has to be remembered first. Then what else? Malassezia, it's a normal harboring. Whenever it is going to have a generalized, it will flare up more. Then ear pathology, if anything is there, most of the cases will be keep on treating the case, but it will be having polyp inside or any growth inside, tumor inside. So we have to identify that and avoid it. Then chemical contact allergens. See, as I told you, the owner will be keep on applying the eardrops. That eardrops itself create allergy. So the eardrops, initially it might have worked out, later it might have developed hypersensitivity reaction. Then atopic dermatitis. So there also you will be having the ear problem. Then cutaneous adverse food reaction. So these are all the things. In our case, we have identified with the ear swab and we have taken a scraping, it was not there. The parasite is not there. And we have taken a tape impression, it was not showing any malassezia. And we have thoroughly examined the ear canal with a otoscope, it was not showing any ear pathology. And the owner is not using any otic preparations. And that's why the chemical contact also ruled out. Then the steroid response is not there. Initially it was there, later it was not there. That means it is not an atopy. Then cutaneous adverse food reaction is the diagnosis. The next case is Caesar, lab, 5-year female. It was having a very severe pruritus, rubs the face, licks the paw for many years. Respond temporarily to Kiskin ointment, antibiotic and antihistamines. Not responding to steroid at all. Even after 3 weeks of steroid given orally. Then vaccination and deworming are proper. So because we have to rule out whether it has got any verminous infestation, because of that pododermatitis is there. So vaccination, deworming, even in case of distemper, you will develop hyperkeratosis. So all these things we have to remember, and we have to ask the question in the history itself. In the clinically, when we examine, animal was having pruritus, dry coat, hair loss, licking the paw, rubbing the face, frequently motion, urine were normal. So what are all the differential diagnoses for pododermatitis? Again, parasites, because in hookworm it is possible. Very commonly in Demodex you will be having interdigital pyoderma. So if you are going to take a hair plug in it, or if you are going to give a tape impression, you can very well identify, because that area you may not be in a position to take a scraping. You can very well do the tape impression and see under microscope large number of Demodex. So that is very important. Then malassezia. See, in malassezia also they will have the problem of pododermatitis. And acrylic dermatitis, psychogenic. The owner is left for a few days and gone. And there is also a possibility to have the acrylic dermatitis. Then contact allergic dermatitis. Any chemical irritant is getting exposed to the leg, there is chance for getting contact allergic dermatitis. Then atopy. Atopy also ear, foot, every ventral abdomen, all the places are involved. So cutaneous adverse food reaction. These are all the differential diagnoses. In this also we have seen the parasite is not there, malassezia is not there, and water is well with the dog. It was there is no chance for getting psychogenic dermatosis. And there is no chance of getting contact with the chemical allergens. And atopy also not there because it is not responding to steroid. Cutaneous adverse food reaction is the diagnosis. And here the Jackie, Dalmatian 1 year male history, kept in well protected clean AC room, had recurrent pyoderma, eruptions, chronic itching, response to antibiotic, antihistaminic and antiseptic shampoos, not responding to steroids. Daily ivermectin was given by locally he treated, and fipronil spot-on sprays and antifungals he has given. It was not showing any improvement. It was presented to me, and when I examined the case, it was having a scratching frequently and hair loss, papular eruptions all over the body. You can see the papule-like eruptions all over the body. So that is the then excoriation, self-mutilation, pustules. So any papular eruptions all over the body means definitely you will be thinking of parasites. So Demodex, even if it is going to be in the top line, you will be thinking of what? Any fleas or mosquitoes. Even that is the chance for getting this like papular eruptions. Even Demodicosis scabies will have this kind of papular eruptions in the early stage. Then malassezia. Then insect bite allergy, as I told you, mosquitoes are very commonest thing to have this kind of allergy. And chemical and shampoo allergy, that is also possible. If the shampoo is not suiting, they develop allergy. That atopic dermatitis and cutaneous adverse food reaction. In that also we have took a scraping, it was negative, and malassezia tape impression, it was negative, and there was no history of any insect bite. Chemical shampoo, what they have been using, the same thing they are using. And atopy, because it is not responding to steroid, we can very well say it is not an atopy. And cutaneous adverse food reaction is the diagnosis. Then sarcogy. This is the case with the vomiting. See, for more than 5 months it is vomiting, and it has been fed with beef, bread, egg, mutton, and mutton severity, that is intestine. Those things they have been feeding for a long time, and immediately after some time it will go for vomiting. That is the history, and it is not improving, and it is having pruritus. That is the history. So here when we stopped, see here we advise to stop everything, stop bread, egg, mutton severity, everything. Dietary trial for 5 weeks, it was showing a very good improvement in this case. So it is a clear case of food allergy. So it can be presented in this fashion. So it is very important to recognize that in a proper way. So the history, you have to concentrate on pruritus, otitis, and otitis, reddening of the ear, shaking of the head, scratching of the ear, licking the paw, rubbing the face, recurrent, it is a recurrent problem, and pyoderma, yeast infestation, GI signs, atopic dermatitis may be there in the dog. Along with that, it will get flare up if you are going to give. See, if the treatment is for atopic dermatitis, will get successfully done only if you are going to avoid these flare up factors. So whenever there is a introduction of chicken or anything which is not done before, all of a sudden if they are going to introduce, again it will develop allergy towards that particular food. So the atopic dermatitis may be there, or flea allergic dermatitis may be there. Along with that, the flare up factors like food allergy will be there. So you have to necessarily check what new introduction of food has been done by the owner. The cutaneous adverse food reaction clinical signs, we can identify non-seasonal pruritus, increased pruritus in the seasonal diseases like food allergy, atopy and flea allergy. So whenever there is a flea in the body, or for hypersensitivity for the flea or hypersensitivity towards atopy, it will flare up when the food is being given newly. Then papules, erythema around the lip, eyes, ear, foot and ventrum, all these places. It will be similar to the atopic dermatitis, but whenever you are going to give a new introduction of treat or food, it will flare up. Then otitis externa media, definitely there is a possibility to go to media if we are not treating it properly. Then concurrent pyoderma microbial overgrowth, malassezia. So all these things are very much possible as a secondary. Then pyotraumatic dermatitis. So it will keep on itching. So it will be having a self-mutilation. The chronic pruritic signs like hair loss, lichenification, hyperpigmentation, excoriation, ulceration, scaling, poor coat, all these things are possible. Then GI signs. That is also one another important signs. In 35% of the cases, you will be having the GI signs. So in our study, we have identified cutaneous adverse food reaction are having, it will vary, but in this case, 82% of the cases were with the food allergy. So you can expect to have ear erythema like this, and superficial pyoderma. That is, you can expect to have this papular eruptions, and early occurrence. That is also one of the important clue. Less than 1 year itself, we will be having the disease, significantly associated with the otitis externa and perianal fistula. That is also one other important clue you can have that has been quoted in different literatures. And you can expect to have the papular eruptions like this, and even moth-eaten appearance is possible to have as a symptom. And you can see the erythema around the snout or in the muscle area, and around the eye you can see the hair loss, and even the conjunctivitis you can have. Around the lip you can have the issue, and even you have the recurrent hematoma. So you will be treating hematoma, but it will reoccur again and again if you are not going to concentrate on the cause. Most common cause for hematoma is allergy. So the allergy has to be ruled out, either food allergy or atopy, you have to rule out. These two are very important reasons to have the recurrent hematoma. So you have to find out that. So even the vasculitis, tip of the ear will be having the bleeding, and it will keep on shaking, animal will be spraying the blood. So you might have seen in certain cases. So you have to check for food allergy in these cases. And acrylic dermatitis. So you can expect to have the lesions in the foot. So keep on licking the area. That is also one another important symptom where you can expect to have. So in these cases, apart from treating the food, changing the food or food allergy, you have to give the psychotropic drugs like amitriptyline to control the problem or solving the problem early. And erythema of the paw, that is also there. And even the seborrhea you can expect to have because of this. All pustules and papular eruptions you can expect to have. Prominent symptoms, what we have done a study in that we have got a recurrent pyoderma, facial rubbing, licking the paw are 49%. And GI signs with the pruritus only 35%. And redness of the pinnae we have only 16% along with the pruritus. So only 16% had only the ear pinnae and pruritus. So the combination of these signs along with the pruritus we have recorded. And we have recorded 52% of the cases were with the chicken and wheat in our area. It may vary from place to place. So chicken was 18% if it is fed alone, and wheat 12.2%, and beef 17.8%, and dairy products 6.8%, and nuts 16%. So we have to necessarily check the treats, and by giving a groundnut treat, we can expect to have the redness. See the conjunctival hyperemia and well demarcated erythematous lesions you can see in the axillary area. So these things are very much documented in various literatures. In case of feline, we can, as I told you, we can expect to have the different type of reactions like miliary dermatitis, eosinophilic granuloma, or mixed, or symmetrical alopecia is one another important sign in case of feline. Symmetrical alopecia. See, there they have identified 65% of the cases with feline dietary allergy, that is food allergy, is with the head and neck pruritus. So the head and neck pruritus is the most common problem in case of feline. And even the self-mutilation, excoriation, you can expect to have in case of cat. And eosinophilic plaque, that is also very commonly seen in food allergy. Like this, indolent ulcers, there is possibility to have. And the important thing is symmetrical alopecia. That is also commonly seen. Both sides will have alopecia. You can see at the sides of the body. You can see the symmetrical alopecia in case of cat. So we have to differentiate the parasites, we have to differentiate the allergies, we have to differentiate the GI diseases. That is a very important area where we have to focus to differentiate. And decision by serological examination, there are a lot of reports stating that dietary elimination trials are the only thing we can expect even till today. Dietary trial is the only way to identify diagnose the food allergy. That is the thing. Serology, intradermal test, gastroscopic provocation test, or intestinal permeability test are not useful in identifying the disease. Even there are certain reports stating that serological tests for dietary allergen specific IgE is limited value. So don't go for it, don't waste the money of the owner. And patch testing with the food antigen was good, but laborious and costly. So they are not useful for a practical application. So it is only way to go for a dietary trial. So dietary trial should begin with beef and dairy products, because internationally it has been recognized as an allergen for all the animals, both dog and cat. So the dietary trial is the only thing we have to follow for identifying the food allergy. That is a very important thing. So the management, we have to check for a bacterial microbial infection like pyoderma, bacterial overgrowth, malassezia, dermatitis, and flea allergy. All these things has to be identified and alleviated then and there. That is very important. Then ideal elimination diet, we can either go for a novel protein or protein hydrolysate. That is what previously thought. But now it has been documented very well. We have to go for a dietary trial mainly with the unallergenic diet, because the unallergenic diet is having less than 1 kilodalton. So definitely it won't create problem. If you are not having access to it, you can very well go for a home diet, for a dietary trial. So misinterpretation of the steroid response. That is also one another important thing. Here the steroid response may be there, or lack of response may be there, partial response may be there. Only short-term response, whatever the steroid given, it will be only short time, it won't be long time like in atopy. So complete remission after avoiding the allergic food is only the way you can identify the allergy. So not following the dietary trial strictly, that is also one another important thing. Dietary trial means it should be, the GI signs should get resolved within 2 weeks. If you are going for a dietary trial, all the gastric signs should get resolved within 2 weeks. Whereas skin signs, that is cutaneous signs, will get subside by 8 to 12 weeks. That's why they have given us a 8 to 12 weeks dietary trial. So if no improvement, negative, and case is not the cutaneous adverse food reaction, owner should contact the vet frequently. That is one another important area where we have to concentrate. You should ask the owner to come every 2 weeks, once in 2 weeks. Then only we can follow the case. Dietary challenge with the formally given food, drinks and treats has to be done. Reintroduce each protein source for 2 weeks in dogs, 1 week in cat, and observe for recurrence of clinical signs. That is the recurrence, licking the paw, rubbing the face, shaking the head, that will occur if it is if you are going to reintroduce the old food, that is the previously given food. If the signs reoccur on challenge, adverse food reaction can be diagnosed. And then provocation. The provocation means to identify the exact protein allergen. Each suspected offending ingredient will be individually added to the elimination dietary formula. Either, say for example, you are giving an unallergenic diet as a dietary trial food. You have to introduce one by one the previous food and see how is the response. That is the provocation. So that we can exactly find out which food is causing, which protein source is causing the problem. That is the thing. So here there are important dietary options for elimination dietary trial. Home cooked diet, it is a gold standard. We can very well go for a home cooked diet as a dietary trial, either with a unexposed novel protein. Say for example, rabbit has not been given for the dog before, so you can give that rabbit and rice. Or pork has not been given, duck has not been given in its life, means you can very well give along with the rice. That is hypoallergenic also. So you can very well try with that and then you can go for it. But only the disadvantage here is may not be nutritionally balanced, may not be suitable for long-term feeding. Then commercially limited ingredient diet, because we have got a certain salmon diet, duck diet, or pork diet, like that we have got different varieties nowadays. Even insect diet is available nowadays. So that these things, the only disadvantage here is up to 80% contain undeclared proteins. They will be adding chicken, but they won't say in label. That is what been identified by so many researchers. So it is very, very important to note that. Then hydrolyzed diet. See, hydrolyzed diet suitable for most of the animal and long-term feeding. But here may see GI upset and weight gain, because there are certain things which can create problems. Say for example, some animals which are allergic to certain protein, say for example chicken is allergic for a dog, means if you are going to give hypoallergenic chicken based, it will develop allergy in those animals. Only certain 2 or 3% of animals, they will develop allergy. That's why they are going for analergenic diet, where you are having less than 1 K delton as a molecular weight. In that, it won't create allergy at all. That's why we have to go for dietary trial, means you have to go for either analergenic diet or home diet with a novel protein. So all the members of the family should be informed in the dietary trial. Dietary trial should be 8 to 12 weeks, 100%, 5 weeks means 80% results. Home cooked diet, novel, limited or single source protein can be tried, or hydrolyzed diet, but we suggest only analergenic diet. Nothing else should be given. Home cooked diet proteins. For dogs, pork, rabbit, venison, duck and fish. Whereas in case of cat, it is not the fish. It is pork, rabbit, venison or duck we can use as a dietary trial. And one another recent study they have given as cod fish and salmon fish. These two are having a genetically cross reactivity with the chicken. So whenever you are going to use any dietary trial or anything, you should not use this fish, that is cod fish and salmon based food. If you are going to use that, it may mimic chicken for certain animals. So it will give you a wrong result. So you should not use that. Even while using regular diet also, if the animal is allergic to chicken, you better avoid this fish. Instead of this fish, you go for a different fish. So this is the 40K denton less common allergy. 14 to 40 most commonly what we are seeing as an allergy. 4 to 13 is reduced allergy. 1 to 3 is highly reduced allergy. Less than 1K is no allergy. That is what the analergenic diet. So 10% of the chicken allergic dogs may still react to hydrolyzed chicken, but they do not react extensively hydrolyzed feathers. That is what the report says in by Risi et al. In veterinary dermatology. It has been published. So it is very important to recognize how the allergy is being developed, because based on the protein molecular weight. If it is going to have contact with the receptors, they develop histamine release, and if it is going to be very small fractions, it won't create any problem. So failure to follow up is one another important area where we are failing. Key for success in cutaneous adverse food reaction is excellent client communication is the key to achieving a successful elimination dietary trial. We have to ask the owner to contact you once in 2 weeks. You have to follow it up. Otherwise, if he is going to come after a year, after 6 months, there is no use, because he will be feeding some other thing in between, and he may not have control over it, and his family member may not have control over it. So it is very, very important to monitor the dog, what is going on in the dog, whether it is going properly, and all those things has to be done only with the communication. So the communication is very important key for success. So how to catch up cutaneous adverse food reaction? The proper history, that is very important. We have discussed all those things. And apart from food, consider treats and medicines, because coloring agents also possible to have the issue. So sometime some B complex, they may have a coloring agents. So even the food, they may have a coloring agents. Even the jirhai like thing, they will be having a coloring agent or binding agents. They only develop problem. That's why we have to, apart from food, consider the treats and medicines. Suspect when the pet has recurrent pyoderma and licks the paw, rub the face, shake the head. These are all the important clinical signs you have to concentrate when the owner is telling this. And recurrent ear erythema, otitis, GI signs. Lack partial short-term steroid response. That also has to be checked. Then confirm by 5 to 8 weeks of strict dietary trial and challenge. So challenge has to be done by we have to do 5 to 8 weeks of trial. Later we have to go for each protein source for every 2 weeks and see the response. That is the challenge. Then closely follow the case till recovery. That is a very important thing. So the take home message here is picking up of information. History is very important. And eliminate the parasite infectious causes before allergy investigation. Extensively hydrolyzed diet is very important to go for a dietary trial. And avoidance of allergic food. That is, we have to identify the allergy, what is causing allergy, then only we can avoid that. Then client education is very, very important. So these are all the things we have to consider. Thank you. So once again, I welcome you all for our Indian Congress for Veterinary Dermatology, which is going to happen in Goa. And you can go for this website for registration. Thank you. Thank you very much.
Thank you, Professor Nagarajan. Any doubts?
A dog with a severe cutaneous adverse food reaction, having severe pyoderma and dermatophytosis, like myelofiscia, severe infection, and having severe itch flare.
Severe?
Itch flare. So how will you, pruritus, how will you manage in this condition? Because steroid, steroid is sometimes counterproductive. How will you manage initially and later on?
You can very well go for antihistamine. So levocetirizine you can continue. Because the self-mutilation is going to happen, it will aggravate the condition. So it will go for a secondary growth, like bacteria, microbes, anything can happen. So it is better to avoid scratching. That is the main idea of treating the allergy. So first and foremost thing is you have to avoid further damage. So for that you have to go for, in case of atopy, you have to give steroid first. Then you have to go for switch over to the other thing. First you have to control. If it is not improving with the immunosuppressants, you have to go for steroid in case of atopy in any form. But you have to concentrate on the damage caused by the steroid if you are going to use continuously. So you have to keep it in mind and use cautiously. Whereas in case of cutaneous adverse food reaction, it is enough to go for antihistamines like levocetirizine or any antihistamine. If you are going to use it, will help very. But you have to identify what is the actual secondaries causing this. What is the flare-up factor which is causing this? Whether it is a flea. If it is going to be a flea, you have to treat the flea. So in all the allergy cases, it is better to treat the flea first. Go for a dietary trial. Then you go for concentrating on the atopy. There you will get success.
Sir, mostly we are feeding, most of the people feeding on egg, sir.
No, not necessarily. Say for example, say some of us are allergic to grab. It is not meaning that all the human beings are allergic to grab. So like that, in dog also, egg is not the only reason to have allergy. It is our duty to identify whether the egg is creating a problem, or milk is creating the problem, or bread is creating the problem. For that you are going for a dietary trial. By avoiding all the food, whatever they have given, you list out. These are all the food possible. It may be a dairy, wheat, nut. It may be a chicken, mutton, beef. These 6 things are very important. So these 6 proteins are very, very important for causing allergy. So first avoid this and go for other options like fish. So in the fish also, cod and salmon is not advisable to go for a dietary trial. It is better to go for some other fish. Or you go for rabbit. You can go for duck, which is available now. Even a lot of companies have brought duck even like Origin, they have got duck food. So it is having duck. Like that, N&D, they have got the duck. So duck food, there is availability of duck food is there, and availability of analogenic diet is there, availability of hydrolyzed diet is there with the Vitpro, and even the Royal Canin they are having. So we have to select according to the need of the animal and the pocket of the animal owner. See, whatever things we will fill up our pocket, that is different. The thing is, we have to assess all these things, see how the patient is reacting, the owner is reacting, what is the comfort nature, what is the comfort zone of them. That is the thing we have to identify and decide what to go, because sometimes analogenic diet will be very costly for them. See, sometime we'll be going for hypoallergenic diet with a Royal Canin, and sometimes they may feel it is costly, they may be switching over to hypoallergenic diet of Vitpro. Like that, there are certain things in the practice we have to, conveniently we have to follow and set according to the nature of the problem and convenience of the owner. That is very important. So, and also response. Sometimes it will respond, one protein, one substance, the same hypoallergenic diet of different companies may not suit for all the dogs. So for Vitpro, it may be suiting. Some other company, Royal Canin, some other dog, Royal Canin will be suiting. Some other hills will be suiting. Like that, individually there will be certain ingredient which may not suit for it, or even certain combination. Say for example, as I told you, if one individual is allergic to chicken, it may be not all the dogs. Some low percentage of animals will be allergic to hydrolyzed protein, which is having the same source. That's why they go for a, say for example, if it is allergic to chicken, they can go for a fish hydrolyzed protein. Say Forenoon is having fish hydrolyzed protein. Like that, we have to identify and understand which will be suiting for that, because which is causing allergy to that individual animal. That we have to understand, and then we have to select. So only if you are going through properly, if you are going into it, then only you can identify all these things. So if anything, you can always welcome to contact me. We will help you.
Sir.
Thank you.
Sir,
Yeah.
one question, sir. What is the incidence of lactose intolerance in Indian dogs and cats?
It is very less only, less than 1 or 2%. Less than 2%, we can say. Even in cattle, we have seen calves, they develop lactose intolerance. But not, it is not so common, but it is there. We have documented in dogs. So we have to identify, the owner themselves will be telling you. See, the food allergy history, owner will be giving lot of clues for you. We have to hear what he is telling. So that may be, you will be thinking that it is a negligible thing, but it may be an important thing. Say he will be telling, when we give egg, it is passing loose motion. When we give milk, it is not suiting. And the owner themselves will be telling, because he experienced from the young puppy, but he will be fixing that it won't create any delayed allergy. That's why he will be thinking that if you give, it has been given chicken for 6 months, but now it is allergic to chicken means what? So they may not know it is having a delayed allergy also, delayed hypersensitivity reaction also possible, that they may not know. First we should know, then only we can deliver it to the client. That is very important. Okay. Thank you.
Thank you very much. We break for tea now. By 12:30 is the next session. So I request you all to be in the hall by 12:20 itself. The next session will be more interesting, which you will be noticing it. Thank you.
Because of this, they trained in Michigan State University. And also recently, many faculties, they gone to, currently is a professor in University of Georgia. There, some of the faculty, they went there and they got trained. And when I gone through his profile in Google, there are a lot of publication in neuroendocrinology and a lot of work in human medicine he has done. So, I welcome Dr. Mohan Kumar sir to deliver his presentations. Please, sir, take yours.
Thank you, Dr. Chandrasekhar. Give me just a couple seconds. I'll take care of this. And then. Okay, so can you hear me now? Okay. So my way of presenting is a little different. I'm not going to let you sit around and talk to each other. I'm going to be asking you questions. So you better be ready. Otherwise, there is no point, I believe anyway. Because if you put something up and you have a PowerPoint, somebody will be standing there and talking. You're going to be doing your own things. If somebody is looking at their cell phone, I'll catch you. I'll ask you questions. I'll look at your ID card and call out your name. So be ready. I'm on your face kind of guy, okay? Okay, so let's do this. Just a couple introductions. So I'm going to be dealing with surgical anatomy of forelimb common conditions. When you think about anatomy, you're always saying, oh my God, so much to remember. I don't remember anything from anatomy. But you all do. You think you don't remember, but you do. Because if you don't remember anatomy, you really cannot be a practitioner. That's the truth. Because when you touch an animal, you are actually feeling anatomy, basically, right? So the way you do it is how it's going to help you in terms of remembering things. So you are all different types of learners, so we are going to use multiple different strategies to help you learn these things, right? So I use all sorts of strategies to teach anatomy. And I not only teach anatomy, I teach neuro, I teach endocrinology. So it's a combination of various things in College of Veterinary Medicine. For example, here, this picture right here, that shows the ultrasound. You probably have seen the butterfly IQ. I use butterfly IQ quite a bit in my teaching. So I use different kinds of models for students to learn ultrasounding. So this is an example of that. So make it more interactive, helpful, and things like that, okay? So what I'm going to do is going to be a case-based thing, basically. So when you think about common issues of the forelimb, so it can be only 4 different things that you can think of, right? So orthopedic, right? The second can be muscular, or it can be neurological, or it can be related to tendons and bursae, right? So one disadvantage we have in India when you study veterinary medicine, we don't get a chance to dissect a dog, right? Nobody dissects a dog here. So because of that, we really do not know all the details about dog anatomy. That's a big impediment, right? So that's one of the reasons. For example, let's take tendons and bursae of the forelimb, right? Can anyone tell me what could be 2 common tendons that can get inflamed and cause lameness of the forelimb in dog? Obviously, forelimb bears 60% of the body weight in any animal. It doesn't matter whether it is dog or cattle or equine. So there are more issues associated with forelimb than hind limb, right? So when you think about lameness, there are 2 tendons and a couple bursa that are very important in the forelimb. And if a dog comes to you with lameness,
weight bearing or non-weight bearing. You need to think about that, right? So can anyone tell me what could be the tendons or what could be the bursae? Did somebody say something? Say it again. Excellent, bicipital bursa. Good answer there. So bicipital bursa. So the bicipital bursa, if I say bicipital bursa, you need to think about where is it located, right? It is located between two structures. What are those structures? It's also called as, bicipital bursa is also called as, what do you have in humerus? What do you have in femur? Is it trochanter or is it tubercle in the humerus? Tubercle. So that's also known as intratubercular bursa. That means it is between greater tubercle and lesser tubercle. If we're going to be examining, if Dr. JP is examining an animal for shoulder lameness as a surgeon, and he is going to be looking at, if he needs to feel for bicipital bursa, then he should know exactly where to go look for it, right? Greater tubercle, is it located laterally or medially? Greater tubercle, is it located laterally or medially? Medial? Nope. Lesser tubercle is medial, greater tubercle is lateral. Why is it important clinically? If you want to access your shoulder joint, if you want to inject something into bicipital bursa, you should know where greater tubercle is located. Because greater tubercle is your landmark to approach your shoulder joint. If you know that, it's very easy. So Dr. JP is feeling the bicipital bursa. He sees pain in the animal. He knows that animal evinces pain. What do you do right away? Easy treatment option. You can be injecting directly into the bursa. You can be injecting an anti-inflammatory drug, whatever drug of choice that you have. It doesn't matter what drug that is. And all you need to know there is your hand. You should know where greater tubercle is, how to palpate your greater tubercle, and put a needle right there, and you will be right there on the spot in your intertubercular bursa. One shot at an anti-inflammatory, the animal will walk nicely in 2 hours. So, simple thing, but it's extremely important. You don't need a radiology or radiologist. You don't need an X-ray machine for that. Nothing. It's just palpation, anatomy knowledge. You can put it in and you can take care of it. Okay, so just an example. So bursae we talked about. So tendon, again associated with that, the internal tendon of the biceps or the tendon of origin of the biceps, right? So just an example. Obviously, in 45 minutes, I cannot cover all this stuff, right? I'm just going to give you some tip of the iceberg examples, basically. So orthopedic, for example. What are some of the common conditions of orthopedic issues that you will see in the forelimb of a dog? OCD is very common. So osteochondritis dissecans. So it's a syndrome, basically, meaning it's a collection of number of things that are named together as OCD. So anything can be OCD, right? So lots of times it's a developmental issue. And a lot of times it is because of avascular necrosis, meaning there is not enough blood supply because of the developmental issue. That particular area is not receiving enough blood supply. You're having issues, right? So that's one thing. What could be another reason you develop a lot of orthopedic issues in the forelimb? Fantastic. So all the ununited issues, not just anconial process alone. When you think about the forelimb, what are some of the processes that you can think of? As you know, the physeal line closes on different days compared to the rest of the bones, right? So when you think about the forelimb, think about the elbow joint. What are some of the processes that you can think of? He already said anconial process. Somebody said coronoid here. Excellent. So you have a medial coronoid process. You have a lateral coronoid process. You have an anconial process. Then there is one more process right there, big one. Olecranon process. Excellent. Can you also tell me what muscle inserts there? Very important. Clinically extremely important. There is a bursa there too. Triceps. Fantastic. So tendon of insertion of triceps is an olecranon process. So because of that, it's very critical. So all these processes, again, a developmental issue. If they don't unite, you will have an ununited disease. It can be an ununited anconial process or coronoid process or an olecranon process. Anything can happen there. Even styloid processes. You go to the distal end of radius. So medial styloid process of the radius, lateral styloid process of the ulna. Right? So they both, if they are not united, you will have issues with that. So you have your varus and valgus and all those issues that could be associated with that. So these are all simple orthopedic issues that you can think of, right? So lots of times, this ununited processes, you need to go and take it out. If you don't take it out, that's what causes lots of issues. For example, the term elbow dysplasia, you would have heard elbow dysplasia. It's a combination of multiple things. So one of the common things that are involved or associated with elbow dysplasia is your ununited anconial process, ununited coronoid process, ununited olecranon process. So if you see them, olecranon process, you can do a stapling. So it'll be okay. And it's important, you cannot take it out. Because if you take it out, triceps cannot insert. What will happen if triceps cannot insert there? What will happen to that forelimb? If an animal loses olecranon process of the ulna, let's say in the right arm, can this animal stand, bear weight? It cannot. Because triceps is the most important muscle for weight bearing. So if the insertion doesn't work, that means it cannot bear weight. Right? So those are some of the important things that you need to remember orthopedically. Okay? Obviously, when these orthopedic issues happen, you need to basically take the surgical approach to go in there and remove it. Again, there comes anatomy. You need to think about what approach you're going to take. Medial approach, lateral approach. What structures do you avoid? What nerves do you avoid? What vessels do you avoid? Because that's all important. You just go in, cut some nerve, and then go pick out that anconial process of the ulna, then the animal will stop standing. So there is no point in doing the surgery. So it's extremely important that you remember all that, right? So now let's talk about muscular. Obviously, there are lots of muscular issues. Cool thing about if you are a believer of God, which I am, so you can say God made this way. Or if you don't believe, you can call it nature, whatever you want to call. Lot of redundancy. So what do I mean by redundancy? Okay, so let's say flexion of the elbow. So we are talking about flexion of the elbow. I'll give you a second to think about it. Flexion of the elbow. What are the muscles that are involved in flexion of the elbow? Biceps, brachii, then? Somebody else said something? What did you say? Come on, say it. Flexor or flexors of the elbow. Biceps, brachii, then? One more. There is one more. You have to know this. Let me ask you this way. No, that doesn't flex the elbow. His name itself is flexor carpi radialis. That means it's going to flex the carpus, not the elbow. Right? So biceps brachii. Let me put it this way. A dog is presented to you. Okay? A dog comes to your clinic. It had a lacerated wound. It cuts its bicep tendon. Okay? This time, let's pick Dr. Jayaraja's clinic. Comes to Dr. Jayaraja's clinic. Of course, he's not a surgeon. He's an internist, right? So he's going to refer to a surgeon. The surgeon comes and examines the animal. Found out that biceps is not working. By the way, how many heads are in biceps? 2, right? Because it's biceps brachii. So 2 heads in biceps, right? So biceps is not working. Can this animal flex the elbow? Somebody said yes. If biceps brachii is the only flexor of the elbow, if that is gone, how can this animal flex the elbow? Say it again. Ulnaris lateralis does not have any effects on elbow joint. You are missing one muscle. That's what I'm coming to. Triceps is not a flexor. Whoever said triceps doesn't get dinner today. Because what does triceps do with elbow? What is the most important function of triceps? Extending the elbow. If you cannot extend the elbow, the animal cannot bear weight. So, I haven't heard the right answer yet. One more try. It's called as flexor carpi radialis. That means it is going to Flux the carpus. So the problem with this is, we all named, I learned this way also. We just list the muscles, we memorize the heck out of them, get up in the morning when you have exam, flexor carpi radialis, extensor carpi radialis, ulnaris lateralis, biceps brachii, triceps. That's what we do. We don't even think about what these muscles do. How is it relevant clinically? Why am I even studying this muscle? Right? So should I say the answer? What do I get if I say the answer? Will you guys buy me a dinner? They are buying me a dinner already anyway. Okay, brachialis is the next muscle. Yeah, so brachialis is located on the lateral aspect. Biceps brachii is located on the medial aspect. If you are going to be fixing humeral fracture, what approach would you take? Medial or lateral approach you would take? Lateral approach, obviously, most of the time, right? Because lots of important critical vessels and nerves go through on the medial side. So you're going to do the lateral side. If you do not know brachialis is located on the lateral side, how are you going to reflect it? Because you're going to be putting a plate or a pin or whatever you're going to do. That makes sense? So, redundancy. Biceps brachii is not working, but still the animal can flex the elbow. It's not in the entire world. Say, somebody was talking, Dr. Nagarajan was talking about, you need to think about the owner's pocket, right? This is a very poor owner, comes to you, and then say the pet biceps is not working. Yeah, it is bad, but there will be fibrosis, it will be okay. You still can flex the elbow, so you don't have to make a big deal about it. You don't have to charge that person 25,000 rupees when they don't even have money to eat their normal regular meals. You can let it go. That's where this knowledge is going to be helpful for you. On the other hand, let me ask you this question. What nerve is responsible for innervating biceps brachii and brachialis? There is another muscle also, which I'm pretty sure you won't remember, so let's not go there. What nerve innervates biceps brachii and brachialis? Radial nerve, no, that person doesn't get dinner for today and tomorrow. Any other guesses? There are only about 8 brachial plexus nerves. Each one of you said something, then I will pick the right answer. So the problem is you should remember all the brachial plexus nerves. That's where the problem comes, right? Musculocutaneous nerve is the nerve that is responsible for innervating both biceps brachii and brachialis. So we talked about injury to the muscle. If you just lose biceps brachii, of course the animal can flex the elbow. But if you lose musculocutaneous nerve, can this animal flex the elbow? Cannot. That's because both the muscles that are responsible for flexing the elbow are gone. You see how they are interconnected and interrelated to each other? That's what you need to pay attention to. Okay? So you cannot separate, this is just an orthopedic problem, this is just a muscular problem, or this is just a neurological problem. You cannot just separate it like that. You need to look at it in a very integrated way. Can we go to the next slide? Next slide? No? I have to do it? Okay. Okay, let's do the clinical example. You can read it. I don't have to read it. I'm just generalizing this clinical example, but we see at least 50 cases like this in our clinic. Very common issue. Everybody read it? Read it carefully because I'm going to ask questions. Good, simple. Whatever the person have a 2-month-old puppy, they're going to work. It was fine, the puppy was fine, active, jumping around. Came back, it's not active, it's sitting in one corner, squeaking in pain, crying. That is the history. Okay? So obviously it's coming to you as a veterinarian. You are asking your veterinary assistant. So Dr. Rangasamy here has an amazing veterinary assistant. You should go see that guy. Oh my God, phenomenal guy. I forgot his name. What's his name? Netaji. Oh my God, he is so good. He's like a dog whisperer. Even give him the worst dog, when he handles that animal, it doesn't make one noise. We should clone that person and train all your veterinary technicians. So, you asked your assistant. The assistant tried to make the animal stand. The puppy is unable to stand. Non-weight bearing lameness on her right forelimb. Everybody okay with that? So I specifically underlined non-weight bearing. Let's not jump to conclusions yet. We will come to that in a second. Yeah, but next one we will do that. It'll keep me young. I can walk back and forth. Okay. No radiography. Right? Cannot take X-ray. You still need to figure it out. How are you going to figure it out? What do you think? How would you go about examining this animal? Tell me that. It's it. So Dr. Sri Kumar is saying by palpation. So where would you palpate for this animal?
From scapula.
You are going to palpate the entire forelimb. Okay. So you will figure out by palpating, let's say, I'm going to say in this condition, point of the elbow is very painful. Okay? Yes. So you know what point of the elbow is, right? Point of the elbow is going to be your olecranon process of the ulna. So when you are palpating in that area, there is a lot of pain there. So apart from pain, let's say there is swelling in that area. You see the difference? There is pain versus swelling. If you have swelling, then you can think about maybe the olecranon bursa might be inflamed, right? So olecranon bursa, when you think about the bursa in the olecranon, there are two different bursa there. Can anybody tell me what are those two bursa are? Clinically important people. This is 15,000 rupees next month in your practice. Now some years are going up. So olecranon bursa has two different types, right? So any bursa, you can think about any bursa. So there are two different kinds, right? One is called as a constant bursa, another is called as an inconstant bursa. So what do I mean by constant bursa? This bursa is present all the time, meaning it is between the surface of the bone and a tendon. It doesn't have to be inflamed. It's just a normal bursa. If that bursa is inflamed, then it is bursitis. If it is not inflamed, it is just a normal bursa located in whatever area that is. In this case, it's going to be olecranon bursa, right? What is the other bursa? Subcutaneous inconstant bursa. So that subcutaneous inconstant bursa is not present all the time. It is present only when the animal uses that area to bear some weight when it is standing up. Big breed animals, Great Danes, Dobermans, German Shepherds, all those big breeds sometimes develop subcutaneous inconstant bursa of the olecranon area. Okay, so let's examine it, and we figured out it's not bursitis. Now what? It's still swelling. What else could be happening there? We just spoke about it. Olecranon process, the ulna could have been ununited. If that is the case, if it is painful, obviously you need radiograph there at that time. You need to look at the radiograph. Then you can probably, because it's such a small puppy, you can do stapling. You can take care of it and it'll be okay. Now I'm going to say they took the radiograph. Olecranon process of the ulna was fine. The animal is still not able to bear weight. What do you think is happening? So same symptom, you can have multiple effects, right? So one thing could be tear in the tendon of insertion of triceps. It can cause swelling. Olecranon process is still intact. It is not working because there is a tear. So animal is not able to bear weight. So it can be orthopedic. It can be muscular, right? So both are possible, right? So let's see what happens next. I'm just giving you an example so that you can think about all of that. And we talked about this already. We did that already. Okay, so let's go to the next scenario. This is the next clinical example. This is a very common example also. I'm bringing this example because you guys do a lot of surgeries and stuff. Once we talk about this, you will never repeat this mistake again. So look at that. 1 inch below the elbow on the lateral side. What are you worried about? Excellent, Dr. Sigmar, amazing, fantastic. So it's radial nerve. So radial nerve exits right underneath the lateral head of the triceps. It's not protected by anything except the skin. So right there, 1 inch below the elbow, if there is a laceration, you have to suspect radial nerve is probably affected. Okay? So here, you need to think about, can this animal bear weight or not? Will this be a non-weight bearing lameness or weight bearing lameness? Anybody? Excellent. Dr. Jayaraja doesn't count, but if you guys can think about it, right? So it will be weight bearing lameness. Why is it weight bearing lameness and not non-weight bearing? Say it again. Excellent. Why is it not affected? Fantastic. Super answer. Give him a big hand, please. Super answer. So, when you think about radial nerve, it has two main branches. One is called as the proximal branch, the other is called as the distal branch. Obviously, when we studied BVSC, we just memorized proximal branch, distal branch, right? We didn't even think about where it went or anything. So proximal branch innervates heads of the triceps medially. Okay? Distal branch comes right underneath our lateral head of the triceps to innervate all the muscles that people were talking about before, extensor carpi radialis, your long digital extensor, your lateral digital extensor, and ulnaris lateralis. But ulnaris lateralis is not an extender of the corpus. It's a flexor of the corpus. It's a weird muscle. That's why we renamed it as ulnaris lateralis. That way you don't get confused with it. Okay? So in that case, again, we don't have any fancy equipment. You are suspecting radial nerve damage. How do you confirm it? One thing you saw already is knuckling. Knuckling is going to be the main symptom. That's because none of the extensors of the corpus are working. Because of that, flexors are overworking. So it is pulling the paw caudally. So it's going to be knuckling. When you see knuckling, but then this animal was able to bear weight, like that gentleman, I forgot his name, like he said, triceps is not affected, so it's able to bear weight, but it's knuckling. So we know, kinda, that it's radial nerve. But you want to confirm it. How do you confirm it? Very easy. No fancy equipment needed. How do you do that? Percussion? Not really. We're talking about, you said something? Won't work. What else? Simple technique. Pinching where? Pinching where? You need to be exactly, because that's very important. So he said pinching, I agree with them, or you can use a pin to check for sensitivity, right? That's what you're talking about. We're going to check the sensitivity, but the important thing is, where do you check the sensitivity? You cannot be checking everywhere and then say radial nerve is affected, right? We are focusing on radial nerve. So how do you know that radial nerve is affected in this animal? Flexor sensitivity works, that means we know its median and ulnar nerve are working, not the radial nerve, right? We need to look at areas. So we just talked about the muscles that are innervated by the radial nerve, right? What are they? Extensor carpi radialis, long digital extensor, lateral digital extensor, and ulnaris lateralis. What are those muscles called? the craniolateral muscles at the forearm. So, Tamil sonnona, the kail in the muscle. If you just do this, you're going to feel those muscles right there. What are they? That's your extensor carpi radialis, long digital extensor, lateral digital extensor, and ulnaris lateralis. So if I want to test the sensitivity, where would I pinch it? Right there. I just put a needle right here, somewhere. Any of these regions is okay. But if you put it right here in the last finger, on the caudal side, you're testing a different nerve. It's called as ulnar nerve. If you're doing it right here, it'll be median nerve, but median nerve doesn't have a specific zone. If you want to test for musculocutaneous nerve, let's say you want to check whether biceps brachii and brachialis are working, where would you test that? Simply remember, where is your biceps brachii located? Right here. I'm going to put a pin right there. What are these areas called? These are called as cutaneous autonomous zones. Okay? There are things called sensory zones, then there are things called cutaneous autonomous zones. What is the difference? Sensory zones, there can be overlap, meaning an area that is sensitive can receive innervation from multiple nerves, whereas cutaneous autonomous zones will receive innervation from one specific nerve. That's why it's clinically important and relevant. If you want to think about radial nerve damage, I'm going to go check the cutaneous autonomous zone for radial nerve. If you're suspecting ulnar nerve damage, I'm going to check that area. If I'm suspecting musculocutaneous, you're going to suspect that area. That makes sense? Okay, so that is our neurological stuff, right? So that's the next example. I have 10 minutes, okay. So we need to go to we talked about it already. We talked about that already. So let's go to this clinical example. I'm going to switch to another PowerPoint for that. Give me 1 second. So this is a case we worked on. Dr. Janet Grimes, board-certified small animal surgeon, was the one who was working on this case. So this dog's name is Riley. And let me give you a little bit more history. Okay, so it's a German wire-haired pointer, 8-year-old. It's a male, castrated male. Notice swelling on the lateral aspect of the right brachium 1 week ago. You see the swelling right there? That's the swelling. Okay? Oh, it's kind of upside down. The video is not showing, but you can see it's still able to play, run around, and everything in spite of the swelling. No function is affected. It's okay. No lameness. It's not painful. So here is another way of doing it. Simple way. If you kind of know the basics of doing ultrasound, again, here is where I use butterfly IQ. Very easy, very simple to use. Because regular ultrasound machines, you need to know every machine is different. You need to know the settings of the machine. You need to know the specific frequency. All those things. With butterfly IQ, it's just one probe. It's a linear probe. It has some limitations, but it'll be very helpful for your daily practice. Right. So you can easily do a musculocutaneous or musculoskeletal ultrasound and figure out what is going on. Here is an example for that. So when you did ultrasound of that area, obviously this is normal muscle structure right there. You see something wrong right here. You don't have to be a big ultrasonographer to figure out there is something going on right there. Right? So that's all you need as a private practicing veterinarian. All you need is you're going to plug your probe and play. You're going to play that area. You found that. Okay. I don't even have a radiograph, but I know there is something going on there. Okay? So let's see what that, so that's normal muscle appearance right there. That's going to be abnormal. It's pretty straightforward. Nothing big. It's not rocket science, right? So this abnormal area, then what we did, this is normal muscle appearance, this is abnormal. Then we took a fine needle biopsy. Very easy to do. You can just go into that area, take it out. you check it out. What happens? This is what you saw. So we are suspecting sarcoma there, right? Not a good thing, right? When you have sarcoma, not a good thing. It's not good news, but it is what it is. So how are you going to remove it? Obviously, we need to go and search for Dr. JP, right? So surgeon, catch out of a surgeon, he needs to cut this thing for me. But as a person, even Dr. JP has to look at, okay, what approach do I take? Am I going to go medially for this? Am I going to go laterally for this? Where is this located? Where is this sarcoma located? Right? So that's what is happening. Okay, so we're going to do all that, right? So before we go there, and I'm going to show you the CT and MR for this, but I'm going to ask you one question. So triceps, right? So we need to find out where this lesion is. How many heads are there in the triceps? Wrong. No breakfast, lunch, dinner for the next 3 days. Triceps has 4 heads. In the cattle and in the horse, it has 3 heads. The reason why you guys remember it's 3 is because you are used to dissecting cattle and horse. But your predominant practice is what? Dog and cat. Dog and cat have 4 heads of the triceps. Extremely important to know that. If this case comes to you, if you're going to operate this, it's important, right? Now, we already said triceps is the most important muscle of the forelimb. It's important for bearing weight, right? Everybody agrees with me on that, right? But there is a tumor in triceps. We're going to remove the triceps. After we remove this tumor, can this animal bear weight? You're saying no? You're saying no, right? You said you should this. How many of you think this animal will not bear weight? Can you raise your hand? Come on, people, we are all friends here. Raise your hand if you think the animal cannot bear weight. Okay, how many of you think it can bear weight? Okay, that's only 4 people, okay. How many of you think, I don't have a clue what you're talking about? There you go, I like that. Honesty is the best policy. So that's good. So we are asking about simple question, right? So triceps, when we just talked about, triceps is the most important muscle and for weight bearing. And here is an animal with a tumor in triceps. We need to remove the tumor. So you need to talk to the owner. Okay, boss, this is a triceps tumor. This person has 1.5 lakhs ready to spend on this dog. I'm a veterinarian. Okay, I'm going to take care of this animal. I'm going to ask. We're going to spend that animal. Then the owner is going to ask you, sir, you told me yesterday this is an important muscle. It's important for weight bearing. You cut this tumor. Can my dog still stand on that leg? You need to answer that person, right? Fortunately, yes, you can. How can you do that? Because it has 4 heads. What is the next question, what is the most important head of triceps that's important for weight bearing? Before that, what are the 4 heads of triceps? So there's medial head, lateral head, long head, and the accessory head. Those are the 4 heads, right? All 4 are innervated by radial nerve, by the way, okay? Out of these, long head is the largest head. Long head is the most important head for weight bearing. As long as this tumor is not in long head, you can remove any other heads and the animal can still bear weight. So this case is about that, okay? So let's look at the CT. Again, CT is all about anatomy. If you don't know anatomy, you are dead wood with CT. So you can observe the right side, the left side. You yourself will know where the lesion is. You see the lesion there? It's appearing right there. Pretty straightforward. You don't have to be a big CT major to know that, right? You have a normal leg, you have an abnormal leg, you can see where the lesion is, right? So that's why this is important, right? So now I'll go to the next one. The mass is seen in the area of the triceps muscle. We know that. Now we need to be very specific about what head of the triceps is what we're trying to get. So cannot tell much more than that because we don't know exactly. So now we're going to do MR. I'm just trying to give you all the possible things that you can do with this dog. Obviously, you don't need to do all of this. If you just actually, with CT, you could have taken care of this. But we had an opportunity to do this because the owner of this animal is an internist at UGA, Dr. Joe Smith. And so we have some leeway with our own CT and MR. If a normal client comes, we will get the credit card first from the client. We will swipe it. And then we will ask them, what is the maximum limit that we can spend on this animal? And they will say, typically $3,000, $4,000. What do you think will be the bill at the end? $4,000. You think we are going to leave $1 out? No. $3,999.99. Whatever the hell test you can do, we will do it. Make sure that we took care of it, right? That's normal. And I'm being honest, that's what every veterinary institution will do. And we are not different. We do exactly the same thing, okay? So in our case, because this belongs to a faculty member, so we could play around with it a little bit. So that's why we did this, right? Now let's see this MR. This is a very interesting way of looking at it. And you can clearly see where the lesion is. You can nicely see your humerus, right? You saw that and you saw the lesion. Did everybody see the lesion? You want me to repeat it one more time? I can freeze it where it is. I'll do this. I'm going to freeze right there. Here you can see nicely. Here is your humerus going up. The condyles of the humerus right there. Cranial aspect, caudal aspect right there. So this is going to be your triceps right here, right? So you see that nicely, right? You can be even specific, okay? So now, here is another view, which is what is extremely important for you to locate and identify where is this located. So here, for example, this is a frozen shot of the triceps. So you need to know, so here is the lesion, tumor. So you need to know all the different heads. You need to figure out what are all the ways that you can approach it. So what is this area right here? Very critical area right there. That's where your vessels and nerves are going. So you can see where this lesion is. Your vessels and nerves are there. You want to make sure that you avoid that. So obviously you are not going to go that way. You're going to go this way. That way, I'm not going to touch that. And triceps is also a very easy muscle to work with because you can separate it. You don't even have to cut through the muscle. You can separate it nicely, reflect it. Just go underneath to this and take it out, right? So now, again, question answer time. So this is a cross section, a schematic of the same thing right there. Okay? So just to give you an idea, I showed you where the humerus is. The red arrow. So you know what the red arrow we are talking about? We are talking about this muscle right there. The question is, what is that muscle? I just have 1 minute, so I'll tell you what the results are. That's your lateral head of the triceps. Okay? So you go to the next one. For example, I'm asking you what is that one right there. You can easily say that's the medial head of the triceps. Once I say all these things, you look at it, it's not that difficult. You see what I mean? So it's because of your familiarity. You are not used to looking at this type of sections all the time in your life. So because of that, it's difficult for you. So it's not a big deal. I'm a kind of guy who studied in Tamil medium all the way till 12th grade. I grew up in a village. Could not speak one sentence in English when I entered veterinary college. So I was like you not too long ago. But you just put your mind to it. You can familiarize yourself. You can do, limitless. You saw some of the beautiful answers that we got. So it's not like you guys don't know it. You know it. It's just applying it. Just bringing it. Somewhere there, down below, just take it out and apply it. It's all we are trying to do. Okay, so next one, for example, what is that? Very good, long head. See, already you know what it is. I don't even have to tell you. So now, obviously, what is that? Accessory head of the triceps. So that's what we're going to remove. So in this case, then we're going to look at all those heads now named. An accessory head is the area that we need to remove it. Now we have labeled all those different heads of the triceps for you to look at. Now, if you go to the next question, what is that muscle? We just talked about it a couple minutes ago. Biceps brachii. You see the relationship? You look at the humerus. You remember the medial side. Remember, we just talked about where is the medial head, right? This is the medial head. Obviously, this is humerus, medial side, lateral side. If this is my cursor right there, okay, that's the medial side. So this is the medial head of the triceps. Just above that, on the medial side, has to be your flexor of the elbow. That's going to be your biceps brachii. Okay, now let me ask you this question. This is located on the lateral side. What would that be? We spoke about that too. Brachialis, excellent. So those are the two flexors, and you can identify them. Once you relate yourself, once you know what is cranial, what's caudal. Number one thing, right? Cranial, caudal. Second set of facts that you need to know. Medial, lateral, done. Once you know that, then where are we in terms of the arm? Are we in the middle of the arm, proximal end, distal end? Once you know that, then you can figure out all the muscles. It's not that difficult. So my suggestion to you as a practicing veterinarian is build this technique of looking at it, visualizing it. As you look at an animal, you should be able to see the organs. See, my problem is, because I've been doing this for so long, when I look at an animal, I see things inside. That's bad. That's because I don't have life. You guys have life. I'm not asking you to be like me, but I'm just saying you should develop it, because if you want to do good ultrasound, you should have that knowledge. Topography is extremely important if you want to do ultrasound. You need to know how are these organs related. You should be able to list all the organs, where they are, right side, left side, how are they related to each other. All that good stuff. As a practicing veterinarian, it's very critical for you. Okay? Okay, so the surgery was done. I'm going to just keep moving. We removed the accessory head, right? And later on, this animal developed other tumors. Okay, so this is the picture from the surgery itself, how it was removed. You can see the lateral side was open, and we can go in and take it out and all that good stuff. And then we need to worry about the nerves and vessels. And radial nerve is located right there. On the lateral side, you can see it's right there. And then all the medial side is right here. So when you go approach the lateral head of the triceps, you can see the radial nerve coming down nicely. When you are reflecting it, you want to make sure that you don't cut it. That's a very common mistake people would make. You want to make sure that you avoid that. Okay? Okay, so I'm going to stop right there. Then we can go over a few other things in the second session. Okay? I'll let him do what he's supposed to do. Any questions?
So we will have a small break now, just 2 minutes, with a lucky dip for you all to relax and refresh for the hind limbs.
Sorry, I stressed you too much.
I request Jagat Pharma to come. So Mohan, yeah, you can pick one. Dr. JP sir, yeah, you have to pick one. Venkatesh, come to the stage. They have 3 lucky winners. We will see who all have answered, whether they are going to win it or not. Sometimes luck and knowledge may not go together. We will see whether it goes. So Mohan first. The lucky winner is Dr. V.P. Sudhakar. Dr. V.P. Sudhakar. Yeah, come to the stage, sir. The second lucky winner. Dr. P. Senapati. Dr. P. Senapati. If he is not in the hall, we will switch over.
Oh, if he's not in the hall, he doesn't get it.
Yeah. Yeah, definitely. It goes to the next person. Yeah. Sir, pick one more. Dr. Bala. Dr. Bala, Sanju Animal Hospital, Chennai. Dr. Bala. Is he here? Dr. Bala. Yeah, goes to the next. இல்லைங்க சார், இருங்க சார். இருக்கிறவங்களுக்கு யாராவது let them be benefited. Those who are not here definitely will not be given. Dr. J. Srikanth. Dr. J. Srikanth. Oh, Dr. P. Revati, the local lady. Dr. P. Revati. Yeah.
Dr. Revati's daughter is going to pick it up on our behalf.
ஒன்றும் இல்லை, அவர் ப்ரெசன்டேஷன் அடுத்தது.
Hello. One more announcement. I request all of you go to the each and every stalls and get sign. Okay? You will be 10 of you people will be getting a money reward, 5,000 rupees. Each person will get a money rewards at the end of the session tomorrow. Okay? People should all should go attend or get a sign from each and every stall of here. Even if you miss one stall, you won't get it. Okay? We will take a lucky dip, and then when you take that number, you should show your card, okay, with all the seal in it. Otherwise, you won't get it. Okay?
I have an announcement also. So I saw a few of you participating, right? So depending upon your participation, if whoever I think participated the most will get an iPad with all the iBooks that we created, as 25 of them downloaded in the iPad, and I'll give it to you. Brand new iPad. So participation, important.
So 10 people, 10 person, we will get 5,000 each. Okay? In check or cash, whatever may be.
Dr. Mohan. Yeah, you can do the next session, sir. So 2 more sessions for you to win the iPad. So please be ready.
Green light, yes. நான் கேள்வி தான் நிறைய கேட்பேன். I'll keep it here. So how was the first session so far, okay? Was it comfortable for you guys? Did I give you enough hard time? Did I give you enough hard time? Say yes loudly. That's what I want. My goal is to give you hard time, okay? No pain, no gain, right? So we're going to give you some pain so that you gain something out of this, okay? Okay, so now I'm going to do the hind limb. You already saw how I approach this. Exactly how I'm going to do the next session also. So be ready for all the structures of the hind limb. Okay? There you go. We start because we have already given all the introductions. How important the orthopedic and muscular and neuro and tendons and bursa and all that. Let's go with a clinical example. Look at this. You are wondering, what is this guy keeps on getting this laceration cases? It's very common. I'm not kidding. It's very common. We see at least 25 to 30 of this every year. I'm pretty sure you see this too. You know, here in India, you have lots of street dogs, light stray dogs. They bite and accidents and fights and all sorts of things will happen. So at least you know now, you can easily diagnose this and treat it accordingly. right? So, pet owner brings his dog, very similar to what we talked about in the case of the elbow. Nobody, no cheating, no looking at internet to look at the stifle and all the structures below the stifle. Don't. It's not going to help you. If you did that, you will forget it right after this session. You go through this exercise, at least you will remember the take-home things. So that's my goal, right? So let's do it that way. Okay. Who is going to talk about what are you worried about? Tibia. You said tibia? Tibial nerve. My God. Do you guys agree with him? He's participating at least. Has a chance for an iPad. What did it? Come on, ladies. You are ruling the world and you don't want to talk? Come on. Sciatic nerve? No lunch, dinner, breakfast for the entire month. Sorry. Okay. Anybody else? Anybody else who wants to cut down their weight and lose some weight? Answer. High five! My God, Mr. Srikant, Dr. Srikant. Awesome, fantastic. So, peroneal nerve, right? So we call it common fibular nerve these days, right? We don't call it as peroneal nerve. Same thing, common fibular nerve is what is called, right? So why is that important? Like our distal branch of the radial nerve, which comes right underneath the lateral head of the triceps, right there in the stifle, common fibular nerve comes underneath what muscle? Think of stifle. Bring it up to you. I know you know it. By the way, there is no difference between equine, bovine, and dogs here. Everything is same. Quadriceps. Who said quadriceps? 1 year, no food for you. No food for 1 year. No food for 1 year, man. That's it. Anybody else? Biceps femoris. You are still proximal. I want you to come distal. So biceps femoris is above stifle, right? So you need to go below stifle. Awesome. Dr. Srikant, you were killing me. My God, another good answer from Dr. Srikant. Yes, it is gastrocnemius. Now the next question is, how many heads are there in the gastrocnemius? Any answers? 4. No food for 5 years. How many heads are in the gastrocnemius muscle? People in the back are not answering. My Michigan State friend is not answering at all. 2 heads. Fantastic. High five. So you have a lateral head and a medial head of the gastrocnemius. Okay? So what do they do? What is the main function of gastrocnemius muscle? Name the joint and what do they do? Extend the hock extends. So these are important hock extensors, along with a couple more muscles who work on the digits. What are they? One is located superficially, one is located deep. Superficial and deep digital flexors. Yeah. They also extend the hock. So the cool thing about the hind limb is it's a zigzag joint, right? So one muscle might extend one joint, but it might flex on another joint. For example, superficial and deep digital flexors, they're going to extend the hock, but they're going to flex the digit. That's very important, right? So if you think about all the extensors, so in the hind limb, we call it common digital extensor or long digital extensor? Long digital extensor. It doesn't matter anyway. I don't care whether you don't remember that. I don't care because it's not clinically relevant. As long as you know that it's a digital extensor, I'm okay. So extensors go down. Where do they go? Digit. You will say digit. Now I'm going to be picky. Where exactly in digit? This is the digit. What are these 3 things? Phalanges, right? P1, P2, P3. Where do they go? Goes to P3. The extensor process of P3. All species. equine, bovine, kangaroos, elephants, rhinos, cats, dogs, rats. Same thing. Very important. Why is it important? Do you guys declaw cats here? No? You don't declaw cats here. That's good. I'm so glad. They're stopping it in the US also. They don't declaw anymore. It's not officially banned, but they don't do it anymore. They kind of frown upon it. So that's an important thing, because when you remove, or when you do declaw, you're going to remove P3. When you remove P3, your long digital extensor is gone, right? Can this animal still extend the digit? What other digital extensors are there? There is only lateral digital extensor. That does only the last 3 digits, so it's not going to be a complete digital extensor. There will be some extension, but not a whole lot. That's why they don't like it. Okay? Now, going back to this question, we said lateral head of the gastrocnemius muscle. So it's going to come underneath the lateral head of the gastrocnemius muscle, and then it is going to innervate all those extensors. These extensors will extend the digit, but they will flux the hock. Remember that. Okay? So the signs and symptoms for this, if you think about it, in this case, if this nerve is cut, obviously you're going to look for the cutaneous autonomous zone. Remember we talked about that? So what is the cutaneous autonomous zone for this nerve? Apply the same analogy that we did for forelimb. So what are all the muscles? Where are they located? Anybody remembering those muscles of the hind limb? Fibularis longus, fibularis tertius, long digital extensor, lateral digital extensor. Those are all the extensors, by the way. So the fibularis longus and fibularis tertius are going to flux the hock, whereas your long and lateral digital extensors are going to extend the digit, right? So if this nerve is cut, this is the nerve that is going to innervate all these muscles. That means flexion of the hock will be affected, extension of the digit will be affected. So that means the animal will still show the knuckling sign again in the hind limb, right? So when I talk about knuckling, whether it is forelimb or hind limb, if it is a complete nerve damage, you have to be very careful. You have to watch for this animal. What will happen is they will keep dragging. They are clueless what is happening because there is no sensitivity also. Cutaneous autonomous zone is gone. There is no sensitivity. There will be wounds there. They will start self-mutilating. They will start eating their own limb. Not a good idea. So either you need to put a brace right away, depending upon what nerve is affected. You can, very easy to do. You can do a brace, and there are lots of good braces that are being sold in India actually. You can buy it, it's not that expensive either. You can do that, or you have to go for amputation. For example, in the forelimb, if it is going to be proximal radial nerve paralysis, you're going to amputate the limb, there is no other go. Because it cannot bear weight. If the animal cannot bear weight, you need to remove the limb. So you need to do what is known as 4-quarter amputation. Meaning you need to remove the entire scapula and out, right? So again, when you do that, you need to think about all the extrinsic muscles of the forelimb, all the intrinsic muscles of the forelimb, the entire brachial plexus, because phantom pain will be there. How do we avoid phantom pain? What kind of precautions you take? All those things have to be remembered. Surgery itself is not that difficult, really. You can ask Dr. JP, he can tell you, it's not that difficult a surgery. As long as you can identify the muscles, go in, and it's not rocket science, and you can do it. So you can do it. As common, regular general practitioners can do it. It's not that difficult. But you should understand what are all the features that you need to be paying attention to. So in the case of this peroneal nerve, can this animal bear weight? That's the next question. Can this animal bear weight? That's the most critical question they're going to ask when a client comes to you. Is this weight bearing or non-weight bearing? Non-weight bearing is more dangerous. It's because, again, they cannot feel, they're going to drag, and all those things are associated with that. So in common fibular nerve damage or the peroneal nerve damage, can this animal bear weight? No. Who said no? You said no, awesome. You said no also. Several of you said no. Excellent point. You don't have to. Now, next question. Can you also tell me what is the important nerve that's important for weight bearing? Hind limb. Forelimb, we said radial nerve. No food for 15 years. So sciatic nerve is the parent nerve for fibular and peroneal, people. Fibular nerve and tibial nerve are going to be branches of sciatic nerve. So it's not sciatic. What else? What is the radial nerve equivalent of hind limb? You said femoral? Did you say femoral? Fantastic answer, femoral nerve. So femoral nerve, you said that? Since she doesn't talk loud, I'm sorry. Squeaky wheel gets the oil. You're not squeaky enough. Then you're not going to get oil, sorry. You have to say it loud. So, yes. So femoral nerve is the most important nerve, like radial nerve. That's what is going to be important for weight bearing. Now the next question, what is the most important weight bearing muscle of the hind limb? Quadriceps femoris, fantastic, super answer. So quadriceps. So quadriceps femoris is equivalent of triceps in the forelimb. Now next question, how many heads are there in quadriceps? Very good. So there is no difference there. Dog, cat, equine, bovine, elephant, kangaroo, doesn't matter. They all have only 4 heads. Now next question, what are the names of the 4 heads of quadriceps? You guys know this. See, already you know my way of saying things. You already got it. Vastus medialis, lateralis, intermedius, and the fourth one is? Fantastic, rectus femoris. Those are the 4 muscles. Out of these, let's say I'm going to have a hypothetical fibrosarcoma of vastus lateralis, and Dr. JP is going in and removing that fibrosarcoma. Can this animal bear weight on this limb? Became silent suddenly. Come on, same thing. Apply the same analogy. Yes, it can. What is the most important muscle of the quadriceps to bear weight? Rectus femoris. There is no long, right? Rectus femoris equivalent of our long head of the triceps, right? So your femoral nerve actually pierces through what is known as your iliopsoas muscle. Iliacus and psoas major comes out and innervates the entire femoral nerve. Now the tricky thing is there a cutaneous autonomous zone for femoral nerve? No, that's the problem. So you really cannot diagnose based on sensitivity whether there is femoral nerve damage or not. The main clue is non-weight bearing. Okay? Everybody good with that? Okay, let's see whether, I think I have a couple more examples. Okay, we did that. We did that. Okay, there you go. For this, I need to go to a different PowerPoint. This is a really cool case. You're going to like it. So this is another thing. I'm just putting a number there for a specific reason. That's the case number. So we have electronics record system. So I can access, if I know the case number, I can access that case from anywhere. I can download as a faculty, as a person who is interested in clinics, I can download any case to my computer as long as I have connectivity. I can do that. It's very important. The visionary leaders of the university, please think of that. So electronic medical recording is extremely important. Make it available for people so that they can access it. Because this is going to be a good teaching tool. This is how I teach. My lectures in general, whether it is anatomy or neuro or endocrinology, is not didactic lectures. I don't lecture. I post a pre-lecture video for 20 minutes. Whatever PowerPoint I make, 20-minute video, post it the previous day, let them know this is where it is posted. They will look at it. They will come back. In the class, I give them 5 minutes to ask me questions on the material that I posted. Once they ask that question, I will have 5 different cases associated with the material I posted. We are going to work together, completely interactive. So I use a specific app called Top Hat. So where people can answer anonymously. See, here you guys are like, oh my God, this guy looking strange. Who wears Namam and Vibhuti in 2023? He says he comes from the US. He's strange. He's asking me questions. He wants my names, right? You don't have to worry about any of that. In top hat, you can give your answer, and I'm not interested what your name is, nothing. But I'm interested in what you guys know as a whole group. So when I came here, I was talking about this to Dr. Sridevi yesterday. So when I came here, I kind of had 4 different lectures in my head. I can use the same slide, non-stop nonsense, right? When you have gift of glib, you can do whatever you want, basically. And this is my job, and I've been doing it, so I can do it quite a bit. So depending upon your response to a specific question that I'm asking anonymously, then I will move my lecture. I'm going to catch Dr. Sinivalan, who's sleeping now. I'll come to you. Cannot escape from me, Dr. Sinivalan. Okay. This is the case. This is Dakota. So caudal thigh gives you a clue. So you have to right away remember what muscles? Caudal thigh. All the semis, right? Semimembranosus, semitendinosus, biceps femoris, all those guys, right? So when you think of those muscles, what nerve comes to your head? All those are innervated by sciatic nerve. That's where you need to think about it. Oh, sciatic nerve. Yes, that's what is the nerve, right? So not affecting ability to ambulate. So we are good. Physical examination. Let me ask you this question. Do you guys get a lot of lipomas here or no? You do, right? Yeah, so. You read that? You're okay? So you see this information, right? We're talking about hind limb. Why are we talking about pectoral muscles and thorax? It's there. Observations, right? We're just writing. That's clinics for you. It's going to cloud your judgment. It's going to show you all different. It's not black and white, is what is taught in med school. It's going to be gray. So I'm just trying to show you there's a lot of gray there. I'm even depicting the area for you. So you can see the mass on the left caudal thigh extended from caudal left stifle to the gluteal muscles, all the way, meaning from there to there, all the way up. Okay? So gluteal muscles, how many gluteal muscles are there in the dog? Three, what are they? Superficial, deep, middle. There you go. 3, there is piriformis, which is part of your middle gluteal muscle, so you can include that. So why am I bringing that up? What's the big deal? Has anyone seen a clinically relevant condition associated with gluteal muscles in your practice? Dr. JP, you have been doing that for so long. Have you seen anything? No. You don't see. Gluteal muscles get extremely rarely affected. So for your practical purposes, you can forget gluteal muscles. But it's very easy to remember. The way the terms that they use are human terminology. Superficial gluteal, deep gluteal. Think about the butt muscle, superficially located, deep. That's how they named it. But in the dog, they're not like that. They're cranial and caudal. So I would rather remember them as cranial gluteal muscles and caudal gluteal muscles. So caudally located gluteal muscle will be your superficial gluteal. Cranially located gluteal muscle will be your middle gluteal and deep gluteal. That's it. Then if I ask you what is the innervation for those? Well, somebody smart has to name the nerves. Cranially located gluteal muscles will be innervated by cranial gluteal nerve. So deep gluteal and middle gluteal are innervated by cranial gluteal nerve. So anatomy is very easy. You just should not memorize it. That's the key. If you memorize it, you are done. It's not going to help you. Okay, so that's the area where the lesion was. So now what's the plan, right? So think about the plan, next steps, you can do all this, fine needle aspirate, because you need to see whether it is what kind of tumor or what kind of mass, it can be an abscess, whatever. So we are going to do that. And then we typically use a body map. You probably know body map, right? It's kind of like a chart where you can list all. So that's what that is. And then we also do thoracic radiographs. Why are we doing thoracic radiographs? Extremely important to look at metastasis, basically. So we do that. And then CT of the hind limbs, because I have your credit card. $3,500. I'm going to use that. There you go. You really don't need a CT for that. I'm just saying. So this is the body map. You can put where things are. And fine needle biopsy was done. We found out that it was a benign fatty tumor. Basically, it's a lipoma. So it can be subcutaneous, it is intramuscular, or infiltrative. The difficult thing is infiltrative. If it is an infiltrative lipoma, you can forget about it. You're not going to take care of it because it's going to keep growing. Because these are precursor cells of fat. Adipose tissues, precursor cells that are located, these are kind of like they have a stemness to them. You know what stemness is? Like they have the ability to expand all the time. So even after you remove it, if it is infiltrative, it'll keep coming again and again and again. So there is no point. Whereas if it is non-infiltrative, it is intramuscular, you can scoop it out nicely. You can just go in and scoop it out. It's not a problem at all. And anybody can do that surgery. You don't have to be a board-certified surgeon or a PhD in soft tissue surgery to do that. Again, thoracic radiographs showed normal, no issues there, okay? So what is going on there? What's going on there? Chip, excellent, so that's a chip. I ask these questions to students all the time. When they look at it, there's something going on there, pathology. No, it's just a chip. Because every dog is chipped in the US, and that's why you see the chip in the thoracic radiograph all the time. Okay, again, other view, looks good, no issues. Now here is our CT there. You don't even have to look at it too deeply. I don't even have a movie there for you. Look at this. You can see a big mass there. So that's the lipoma for you. So you need to remove that lipoma basically. And you can see the video there. You can see how big that lipoma is, the same lipoma on that side. You can see lipoma on the other limb also, so both limbs have it. And here is a picture that basically labels everything for you. I'm not going to make you name the structures again. It's there already, so you can look at it. So basically, you can see where the mass is. You can go in and take it out. It's underneath your biceps femoris, because that's the lateral side. You can see it's right underneath your biceps femoris. So the main thing that you need to pay attention to, what nerve comes down there? Sciatic nerve. Sciatic nerve, before it branches into tibial nerve and peroneal nerve, it runs a sciatic nerve there. So your semimembranosus, semitendinosus, biceps femoris, all these muscles get multiple branches coming out of sciatic nerve, innervating those structures. So you want to make sure that you don't cut them as you are removing the lipoma. That's the most important thing. In the process, if you cut the nerve before it branches into tibial and peroneal, then both your flexors and extensors, the digit will not work. The animal will be still able to bear weight, but it'll be all loosey-goosey. It'll be like this. Can't do extension, it can't do flexion. It'll be like this. This is another problem that happens with improper placement of intramuscular injections. That's why we always say, don't go for thigh muscles. Because if you look at it here, unless you know the difference in that groove there, if you don't pay attention to that, if students put it right there, if it is oxytetracycline, when we were students, oxytetracycline intramuscular was the drug for treatment of every and any disease. So you injected intramuscular, it's such a caustic drug, it's going to cause neuroinflammation right there. You might lose the sciatic nerve completely. That means both your tibial nerve and peroneal nerve are gone. Okay, so want to be important, pay attention to that carefully. So here is another technique I want to share with you. Give me 1 second. I'm just naming structures there. It's no worries. Again, I'm showing you the nerve there, what we just talked about. And the surgery was done. And we used this for planning and everything. Remove the mass. Everything is good. You can see how big the mass is. It just scoops out nicely. On surface, it looks very small. You can see how small it looks right there. But then you go in, you can literally go in with your hand and take it out. And this is the actual mass. So everything else is okay with that animal, and that is the whole extent of the mass after it was removed completely. The dog was carrying this around all the time, poor thing. Okay, so another thing that we can do that we use normally for planning, okay, that's reconstruction. So I do this all the time for clinicians. So if somebody gives me a DICOM file from a CT or MR, I can reconstruct the whole animal. So what do I do is, apart from dissecting a cadaver, we also virtually dissect these specimens. So we can do planar dissections. Why is that important? Anatomy is not going to show up for you in the clinic with a dead dog lying on its back like this, right? You're going to see a live animal. So you need to relate whatever anatomy you learned and apply it to the clinical situation. So most of the time, anatomy shows up for you in the clinic in terms of ultrasound, in terms of radiographs, in terms of MR, and in terms of CT. So understanding cross-sectional anatomy is extremely important. When I give you a cross-section of any specific area, you need to quickly identify what is cranial, what is caudal, what is medial, what is lateral, what section of the limb it is in, and what are the muscles that are associated with that, what vessels and nerves come there. That's all extremely important as a clinician for you to plan your surgery or whatever procedure that you are doing, right? So for that purpose, we start doing that right from first year, okay? So let me show you an example of that. Give me 1 second. What happened? That does not help me. Huh. It is working, right? Okay, I'll go with this. Give me 1 second. The internet is giving me a hard time. There you go. I always rely on my phone more than internet that is available. Okay, so you can see this is a reconstructed animal. I can turn this animal around every way I want to, depending upon where this image was taken from what area. I can turn it around however way I like it. Okay, I can zoom in and can zoom out. All sorts of stuff I can do with this. Okay, for example, here it's very obvious. You can see where the lipoma is on that leg, where the lipoma is on this leg. Okay, for example, I want to understand what specific heads or specific area of the muscle that is involved in it, and I want to plan a surgery. How do I do planning of the surgery? So, for example, here I can go to what is known as a clipping mode, meaning I'm ready to dissect it. So I'm going to clip it now. I'm going to add a plane because it is planar dissection. You can go dorsal ventral, or you can go craniocaudal, or you can go mediolateral, or you can also rotate it, and you can do things like that. Okay, I'm just going to take a simple example. I'm going to add a plane. This is going to do from lateral to medial. Let's say I'm not interested in that. I'm going to say next plane. Okay, this is going to do us dorsal to ventral. Let's take this example. You can see I'm just moving it so that you can see it from dorsal to ventral. And it's very simple. You don't have to be very technically sound in computer or anything to do this. Construction part takes time, which I do. I learned how to do that, so I do that. So if I toggle this, and we use Xbox controllers for this. So I secured $1.5 million to set this up in the lab. So every student has access to it. We will have a video Xbox controller. They will use that to dissect this. I'm talking about first semester of first year in the vet school. So you can see if I am going to dissect it, I'm going dorsal to ventral. Look at that. You can obviously see where the lesion is. Now, this gives me an opportunity to ask lots of questions of what is the structure right here? What is this bone right here? What is that bone? What is that? What is this? Is this trochanter or a tubercle? What muscle is there? What is trochanteric fossa? I can ask all sorts of questions associated with that. That way, people are, into it, interactive. I don't even talk to them during this time. I post all these materials the previous day. Dr. Rangasamy, in fact, attended one of those sessions. So they just have fun. I ask them a bunch of questions, clinical questions related to this. They have to answer it. They have to post it for me. I grade it, provide them the points for that. So it really is helpful because this is going to give you, this is how anatomy is going to show for you in the clinic. So now if they can identify these structures, then they can really read CT and MR. So that's the whole idea. So I was talking to Dr. John about it. So CT and MR, you can come to a place and then see how it is set up. But that's not important, that anybody can set it up. So CT and MR is about how do you interpret it? What is affected? What area is affected? That means you need to really know the anatomy very well. And you need to look at it again and again and again. Then it makes sense, okay? Okay, so for example, if I say cancel ad right there, if I want to use the same material, I created this material, I'm going to come down here. Let's say I want to look at all the structures that are located on the lateral side of the thigh, the muscles, the bones, the vessels. You can do that by sectioning it on that side. Let's say this is the caudal end of the animal, and Dr. Sridevi is here. So if I'm interested in looking at the reproductive structures in this animal, I want them to know what are all the pouches, which we don't teach in our anatomy classes. How many of you know all the pouches in the caudal side of the animal? Raise your hand. If you don't know that, you cannot be a good reproductive medicine practitioner, sorry. You should know all the pouches. Why do you have to know? Because that's what is going to tell you dorsal to ventral, all the organs that are located. If you put a probe, ultrasound probe, on the ventral aspect of the abdomen, and you called it, oh, I see the rectum, I will say, no food for you for your entire life. You are done. You see what I mean? These are important things that you need to learn. So that's why this kind of modeling is very helpful for you. So if, for example, if I want to zoom out, I'm just zooming out for you. You can see the colon now, descending colon right there, right? So what do you see here, right there? What is the side? Left side, right? What are you going to see there? That's the spleen still coming out. There's a little bit of splenomegaly on that animal. It's probably under pentobarbital anesthesia. So because of pentobarbital, there's going to be splenomegaly, so you expect it. So that's what you see there, right? So for example, in this case, I can just go, let's say, add a plane, and let's see, that way I don't want that. I want cranial to caudal. There is cranial to caudal. If I just go this way, I should go next plane, sorry. Yeah. There you go. I can go caudal. I can talk about all the structures, keep going caudal. So what is this structure right there? Cursor. Dakota is a male, right? So that's your aspin is showing up basically. So if you know your anatomy, you can figure out all that. Yeah, CT, you can do it with MR also. CT, MR, both of them, I can reconstruct an animal from any of that. How is this useful in neuro? Because in neuroanatomy or in neurology, this is extremely useful, which I teach. What I do is, I take solid, good sequencing, good sequences. You need to select good sequences of MR. You take the whole brain with lesions or spinal cord with lesions, and then we go back and forth. You can clearly see intervertebral disc prolapse. You can see where there is narrowing of the spinal cord. You can see where there are issues associated with the spinal cord. If it is brachial plexus, okay, what are all the segments that are involved? Is this 5, 6, 7, T1 and T2? And if you know the exact segment, then you can think about what nerves might be involved. You know, all that stuff. And we will talk about that in the afternoon. Or tomorrow, I'm sorry. So I'll stop right there.
Thank you, Dr. Mohan. Now, I think I should have his classes in future in the afternoon so that there will be a good attendance and people also will be attentive. And anyhow, we break for lunch now and we assemble here again by 3 p.m. with the lecture by Dr. Jayaraja on case studies in canine cardiology. And by 3 o'clock we will meet again. We'll break for lunch now. Thank you.